Little boy of 13 was on his way to school. He heard a crowd of people laughing and he went to take a look. Thousands were listening to the stories of one man. He spoke with such wisdom, even the kids could understand. The hours passed so quickly, the day turned into night. Everyone was hungry, but there was no food in sight. The boy looked in his lunchbox at the little that he had. He wasn't sure what good it'd do. There were thousands to be fed, but he saw the twinkling eyes of Jesus, the kindness in his smile, and the boy cried out with the trust of a child. He said, "Take my 5 loaves and 2 fishes, do with it as you will. I surrender. Take my fears and my inhibitions, all my burdens, my ambitions. You can use it all to feed them all." I often think about that boy when I'm feeling small, and I worry that the work I do means nothing at all. But every single tear I cry is a diamond in his hands. And every door that slams in my face I will offer up in prayer. So I'll give you every breath that I have. Oh Lord, you can work miracles. All you need is my amen. So take my 5 loaves and 2 fishes, do with it as you will. I surrender. Take my fears, my inhibitions, all my burdens, my ambitions. You can use it all. I hope it's not too small. I trust in you. I trust in you. So take my 5 loaves and 2 fishes, do with it as you will. I surrender. Take my fears, my inhibitions, all my burdens, my ambitions. You can use it all. No gift is too small.
Good morning to all of you. Okay, happy Sunday. Yan, sana online kayo. Okay, let me see your faces okay, before we start. Okay, please open your cam, guys. Sa mga present, mga pangilan-ngilang present. Hi, Emily. Okay, good morning. Yan, si Maribel. Na? Okay, good morning. Sino pa? Yung iba tulog pa, no? Nasa higaan pa. No? Mga strategy. No? Gawain ko din yun. Okay? Alright. Good morning, Ronaline Reyes. Ayan. Good morning, Catherine. Okay. So, apat pa lang ang gising. No? Yung iba nasa higaan pa. No? Nangumuni-muni. Okay. Huwag na nating patagalin. Okay? Kasi 8:24. It's already 8:24. Okay? And our target time for the conclusion of this training is 12 to 12:30 or 1. No? Kasi meron pa tayong phlebotomy lecture. Okay? All right. We have the first topics, okay, which are the therapies or the management, okay, in advanced cardiac life support. Okay? All right. So good morning everyone again. Pwede na kayo mag-turn off ng cam, no? Okay? Para mabilis yung reception nyo. Okay? Thank you very much ako din. Okay? Wait lang guys, ha? Okay. Since we've already discussed, okay, the dysrhythmias or the types of dysrhythmias yesterday, okay, let's discuss naman kay the different therapies in ACLS, okay? All right. Specifically pertaining to the different types of dysrhythmias, okay? All right. I mentioned yesterday, okay, that we have three major causes of cardiovascular compromise in advanced cardiac life support. And these are the dysrhythmias, acute coronary syndrome, and stroke. Okay? All right. We have three therapies okay, that should be considered, okay, during resuscitation, no? And specifically for dysrhythmias. These are the mechanical therapy, electrical therapy, and the pharmacological therapy. Mechanical therapy, okay, is simply the CPR. That is the reason why we have the basic life support. Okay, all right, and it is indicated, no, okay, to cardiac arrest. All right. Aside from the mechanical therapy, we also have the electrical therapy. The use of electrical shock, okay, to terminate or treat, no, the current dysrhythmia. Okay. And we have the pharmacological therapy, right? Okay, or the medication, okay? Right. The pharmacological therapy, okay, is divided into three, okay? Medication or pharmacological therapy for the bradydysrhythmia, okay? For tachydysrhythmias, and for cardiac arrest. All right? Okay, so you can expect that we have just few, no? Okay, ACLS medications. Okay, so if ever you encountered, okay, an unusual, okay, medication, okay, compared to what you are experiencing, no, in your practice, okay, make sure hindi nyo i-contradict, no, kay yung team leader or yung doctor nyo. Okay? Kasi the guidelines and standards, okay, of the advanced cardiac life support, okay, for emergency cardiovascular care are just recommendation. No? Okay? However, okay, these are standards that can be adapted. Okay? Pero, okay, what you are doing, no, in your hospital, okay, or the protocol of your hospitals, no, okay, are the most important thing to follow. Okay? Kasi yun ang magsasave sa inyo when it comes to legal, no, okay, matter, no, okay, in your workplace. Okay? All right? So, wag niyo sabihin na hindi po kasi sabi sa ECLS hindi daw po yan binibigay, na. Okay? All right? Okay, there are other medications as well, okay, that are used, no, okay, in the practice pero not included in the pharmacological therapies in ACLS. All right? Okay, so that is just my disclaimer or disclosure. Okay? All right. Let's start kay the pharmacological therapy with the bradydysrhythmias. Okay? Again, okay, these are the dysrhythmias with a rate, no, okay, of, okay, slow, no? All right. We have what we call symptomatic bradycardias, no? Okay, and symptomatic bradycardias, okay? So before we give the therapies, okay, we should assess the patient's status, no? Kaya dalawa lang naman ang status, okay, na pwede nating ma-assess sa patient, okay? The unstable and stable status, right? Okay, so the bottom line, okay, of choosing, okay, the therapy for the status of the patient is, if the patient is still stable, okay, you have to choose you have to give the pharmacological therapy. If the patient is already unstable, okay, in tachydystrhythmia, okay, you have to give the electrical therapy. But in bradycardia, we do not have any electrical therapy. Okay, all right. But then again, okay, we have to assess first, okay, the patient condition. Okay, and the assessment discussion will be later, no? Okay, sa algorithm discussion natin. Okay, all right. Now, for the symptomatic bradycardia, okay, we support the patient's airway and breathing. Okay, and of course, we give oxygen if indicated. Ventilation, start an IV, and the medication of choice is the atropine sulfate. All right. Okay, the atropine sulfate increases the heart rate and increases conduction velocity. Right? The dosage, okay, is 0.5 milligram, okay, IV every 3 to 5 minutes, a total dose of 3 milligrams. Okay, the usual dose, okay, or the usual stack dose of atropine sulfate, okay, is 1 milligram per ml ampule. All right. Okay. For pedia, no? Okay, I included the pediatric dose here. Okay? Kahit na pang pediatric advanced life support 'yan. Okay? All right, for the pedia, okay, we have 0.02 milligram per kilogram IV or IO. Okay? Or 0.04 to 0.06 milligram, okay, per kilogram endotracheally. All right. Aside from IV administration of medication, we also have another route, okay, of administration. Okay, these are the intraosseous, no, or IO, and endotracheal or ET. Okay. All right. For intraosseous, okay, we insert an intraosseous needle. Okay. To or in into the specific areas, no, of the body, no, specifically or most commonly the bone below the knee and above the knee. Okay, all right, and this is more common in children, no? Okay, the IV line is directly, no, directly into the bone marrow, right? However, okay, to prevent, okay, the trauma, okay, to the bone marrow, okay, it must be temporarily, no? Okay, it must be in place temporarily for about 5 to 6 hours only. Okay, all right. As long until, okay, we can establish or we can obtain, okay, the IV line. Okay, kasi there are times na mahirap mag-insert ng IV, lalong-lalo na kung in-shock yung pasyente. Okay, all right. Endotracheally, okay, there are medications that can be given endotracheally. Okay, all right. Specifically, the atropine sulfate, the epinephrine, the lidocaine, and naloxone. Okay, yun lang, no? In ACLS medications, yun lang, apat na yun ang pwede nating ibigay endotracheally. Again, okay, we have the atropine sulfate, epinephrine, okay, lidocaine, and the naloxone. Right? Okay, if we consider, okay, the medication to be given endotracheally, you have to double the dose, okay, of the medication. So if we have 0.5 milligram, no, in adult, okay, if we consider the endotracheal administration of the medication, okay, you have to double the dose, okay, that would be 1 milligram. All right. Okay. Okay, precaution, okay, for the atropine administration, do not push slowly, okay, it must be rapid IV push or in smaller than recommended dose, okay, kasi the effect, no, okay, is mas papababain pa niya, no, yung heart rate ng pasyente. Okay, all right, if given in smaller than recommended dose. The use of this drug may result in tachycardia, palpitations, and ventricular ectopy. It means, okay, the atropine sulfate is proarrhythmic. No, proarrhythmic means it can precipitate or trigger, okay, different types of dysrhythmias aside from the bradydysrhythmias. Okay, so you have to monitor the patient closely. Okay, all right, now if you've already consumed, okay, all the or the maximum dose of the epinephrine, okay, and the bradydysrhythmia is still persistent, okay, or recurrent, okay, epinephrine is the is another medication that can be considered. No? Okay, it is a temporizing measure for the management of symptomatic bradycardia that has not responded to atropine or for which atropine is inappropriate while waiting for a pacemaker. Pacemaker insertion, okay? I think I mentioned this no yesterday. Okay, atropine is the indicated therapy, okay, for or advanced therapy, okay, for the symptomatic bradycardia, okay, that is not responding to any medication, okay, right? That is the intravenous pacemaker, okay. All right, and that is more complicated, no? Okay, so pang advanced na yan, pang doctor na pala, okay. All right, epinephrine is also given, okay, for hypotension, okay, but that is not this is not the first line, okay, of treatment for hypotension. It is the dopamine, okay. It can be given also for cardiac arrest. Actually, okay, this is the single most, or I mean, this is the primary medication for the cardiac arrest. Okay, all right. It can be given, okay, to all, okay, cardiac arrest dysrhythmias. Okay, basta walang pulse ang patient, we have to initiate epinephrine, okay, administration. Okay, all right. Now, okay, for symptomatic bradycardia, we have to give, okay, the epinephrine, okay, as infusion. Infusion means there is a dilution, a specific amount of dilution to be given as side drip, no? Okay? Pero ang tawag kasi doon is, okay, secondary, no? Infusion. All right? Okay. The dosage is 2 to 10 microgram per minute, and there is a specific calculation, okay, for that, no? Okay, and it differs, no? Okay, um or it varies, no? Okay, in based on the discipline. Okay, for example, may mga doctors na iba yung computations talaga nila. Okay? All right. For pedia, we have 0.3 microgram, okay, per kilogram per minute. Okay? All right. For cardiac arrest, okay, we have to give 1 milligram. Okay, that is the usual stock dose of the epinephrine is 1 milligram per ml. Though, meron tayong, just like what you can see, no? Okay, in the screen, okay, we have the vial, no? Okay, in 50 ml, in 30 ml, 20, 30, and 50 ml. Pero I don't think meron tayo yan dito sa Philippines. Okay, we have the ampule, no? Okay, more common. Okay, all right. We have 1 milligram, okay, IV push, okay, followed with 10 to 20 ml fluid flush, okay, and can be repeated after 3 to 5 minutes. Okay, all right. So if the doctor, okay, says please give 1 milligram epinephrine, okay, every 3 to 5 minutes. Okay, so do not expect for the doctor to repeat, okay, the administration of epinephrine every 3 to 5 minutes. Okay, so if you are the medication nurse, okay, you must know, okay, that the epinephrine must be given every 3 to 5 minutes. Okay, para dire-diretso, no? Okay, kasi sometimes makakalimutan din ni doctor yun. Okay, sa dami nilang iniisip. Okay, all right. So for the tracheal, again, okay, you have to double the dose. Okay, for the pedia, okay, the dosage is below, okay, 0.01 milligram per kilogram. Okay, right? And for endotracheal administration, we have 0.1 milligram per kilogram. All right. Dopamine, okay, is also a temporizing measure for the management of symptomatic bradycardia. Okay, just like epinephrine. Okay, all right. But for a significant, no, okay, hypotension, okay, the dopamine is the first line, okay, of medication. Okay, all right. Okay. Now, okay, for symptomatic bradycardia, we have 5 to 10 microgram per kilogram per minute. Okay. We have to limit, no, okay, the dosage of dopamine to 10 micrograms, okay, per kilogram per minute, okay, if the purpose is the dysrhythmia management. Okay, but for hypotension, okay, it can be given up to 20 or 30 micrograms per kilogram per minute. Depends on the assessment of the doctor. Okay, all right. Now, okay, there are instances, okay, or events, okay, that the hypotension is caused by hypovolemia. Okay, so make sure, okay, you know the cause, okay, of hypotension. Kasi even if we give, okay, a significant amount, okay, or dosage of dopamine, okay, for hypotension caused by hypovolemia, okay, it will not be corrected. Okay, we have to correct first the hypovolemia, okay, before treating the hypotension. Okay, all right. Now, for us, as per nursing consideration, okay, you have to use the infusion pump no, every time we infuse the dopamine kasi it is somehow irritating drug, no? Okay, and it can cause extravasation when there is an infiltration, right? Okay, and we do not usually stop, okay, the administration or infusion of dopamine. Okay? Kasi there is a possibility that the blood pressure will drop, no? Okay? Immediately. Okay? So we do tapering and titrating method. Okay? All right? Okay. Now, those are the three medications that can be given, okay, for symptomatic bradycardia. Again, we have the atropine sulfate, we have the epinephrine, okay, and we have the dopamine. However, epinephrine is also okay for the cardiac arrest, okay, and dopamine is also for hypotension. Okay, all right. Atropine sulfate is the first drug of choice, okay, to increase the heart rate. Now, specifically, okay, for the slow, no, dysrhythmias. All right. Now, let's discuss the anti this the medication, okay, for the tachydysrhythmia. Okay, all right, and this is called, and these are called, okay, anti-dysrhythmia medication. Right? Okay, we have adenosine, beta blockers, and calcium channel blockers, no, primarily. Okay, but in practice, okay, there are doctors na uh, may meron pa silang iba, no, kay the medication such as sodium channel blockers, digitalis, yan, mga ganyan. Okay? Alright? But we will not discuss all. Okay? Kasi it's not included, no? Okay, in the ACLS standards. Okay? Alright. So adenosine, okay, is a medication specifically given to SVT. Okay? Pag nakakita kayo, okay, ng stable narrow QRS, regular tachycardia, stable narrow QRS, regular tachycardia, this is SVT. Okay? All right, now you have to take note of this, that adenosine must be given, okay, to SVT only. Okay, all right. If accidentally given, if adenosine is accidentally given to other dysrhythmia, okay, for example, irregular, okay, QRS, irregular wide QRS or irregular narrow QRS, okay, wala namang mangyayari sa patient. Okay? Kasi the adenosine has a very few, no, side effects, no, and the side effects are not lethal, right? Okay, kaya lang the cost, no, okay, or it costs about 4,000 to 5,000. Okay? So parang nag-aksaya ka, no, ng pera pag binigay mo to sa maling dysrhythmia. Okay? All right? So it is only given to SVT. Okay? All right. The usual dose, okay, or the usual stock dose, okay, of the adenosine is 6 milligrams, okay, per 2 ml. Okay? Ampule or vial. All right? Okay. The dosage is 6 milligrams, no, rapid IV push for the first dose. And that must be in a rapid IV administration. Okay? All right? About or over 1 to 3 seconds. Okay? Mabilis na mabilis to dapat. All right? Okay. With a following flush, no? NSS flushing or normal saline flush. Okay? All right? Okay. After 2 minutes, okay, you have to assess the patient, no? If the patient is still stable, okay, and the SVT is still persistent or recurrent, okay, you can give the second dose, okay, which is double the dose, okay, the 12 milligrams. Again, okay, the adenosine must be given in very rapid IV push over 1 to 3 seconds, okay, with a following 20 ml or 10 to 20 ml normal saline flush. Okay, you can raise the arm, okay, for 10 to 20 seconds, okay, to facilitate the gravity. Okay, right? Okay, for the pedia, okay, we have 0.1 milligram, okay, per kilogram. Okay, and the second dose is 0.2 milligram per kilogram. Okay, right? Binibigay din yan, okay, for pediatrics. All right. Okay, the common side effect, okay, or adverse effect, okay, of the adenosine is burning sensation of the chest, right? Okay, but it usually resolved, okay, within 1 to 2 minutes. Okay, so you have to reassure the patient that it will last, okay, for or after 2 minutes. Okay, kasi baka mag-panic siya, no? Okay, medyo mainit daw, no, sa dibdib. Okay? All right. You have to constantly monitor the ECG, okay? Kasi sometimes, okay, the first dose, okay, is enough, okay, to convert, okay, the SVT to normal, okay? But sometimes, okay, the SVT is recurrent, okay? All right? And of course, okay, for the documentation, okay? All right. So aside from adenosine K, we also have the calcium channel blockers, okay? But the calcium channel blockers is not only indicated to SVT, okay? But also, okay, for the atrial fibrillation in atrial flutter in RVR or rapid ventricular rate, okay? All right. We have two most common calcium channel blockers, and these are the diltiazem and verapamil. Okay, for the diltiazem, okay, we have 0.25 milligram okay, per kilogram slow IV push. All right, kasi 2 minutes, no? All right. Okay, now let me give you okay the precautions and considerations for all anti-dysrhythmia medications. Okay, all right. All anti-dysrhythmia medications okay share the same precautions and considerations, okay? Other than adenosine, okay? I'm talking about maliban na lang kay adenosine, okay? All right. Okay, so, okay. All anti-dysrhythmia medications must be given in slow IV push, no? And that is a minimum of 2 minutes, okay? Or, okay, there are others, okay, that should be given for 5 minutes, okay, for 10 minutes or 15 minutes, okay? So you must know, okay, the the considerations okay, for the different types. Okay, all right. Um, they have the same adverse effects, no? Okay, which are hypotension, okay, and slow heart rate. That is the reason why we do not give the anti-dysrhythmia medications, okay, for slow ventricular rate. Okay, for example, in atrial fibrillation, atrial flutter, in RVR, we do not give okay we do not give the anti-dysrhythmia medication, or else okay the heart rate will slow down, no, even more. Okay, all right. Um, the next dose, okay, after the first dose, okay, must be given after 15 or slash to 30 minutes. Okay, all right. So therefore, okay, the assessment interval, okay, between each administration, okay, of the dosage of the anti-dysrhythmia medications must be 15 to 30 minutes. All right? Hindi ka pwedeng bumaba ng 15 minutes. All right? Kasi or sa recommended interval kasi pwedeng mag-overlap, no? Okay, yung dosage niya doon sa loob. Okay? All right, so magkakaroon ng overdose. Okay? Clear? All right. Now again, for the diltiazem dosing, we have 0.25 milligram per kilogram, okay, in slow IV push. Okay, and if needed, okay, follow in 15 minutes or after 15 minutes, you have to check for the status of the patient. If the status is still stable and the dysrhythmia is recurrent or persistent, you can get a second dose, which is 0.35 milligram per kilogram. Okay. All right. Verapamil no, is more common than the diltiazem. Okay. In the brand name of Isoptin. No? Okay. And ito yung mura kasi to. No? Okay. Compared sa adenosine. Okay. All right. The dosage is 2.5 to 5 milligrams. Okay. Slow IV push again. Okay. And can be repeated with 5 to 10 milligrams in 15 to 30 minutes. All right. For a maximum dose of 20 to 30 milligrams. Okay. All right. Okay. Um, Additional consideration, okay, for the calcium channel blocker, okay, avoid, okay, giving the adenosine, okay, for wide QRS tachycardia specifically, okay, it can precipitate ventricular fibrillation, okay, all right, so again, okay, you already knew, okay, what the wide QRS tachycardia looks like, okay, that is just a ventricular tachycardia, huh? Okay. Aside from the calcium channel blockers, we also have another blocker. No? Okay, we have the beta blockers. No? Okay, the beta blockers are the olol. Okay, all right, and it is indicated. Okay, for just like the indication of the calcium channel blocker. Okay, it can be given to SVT, okay, to atrial fibrillation, atrial flutter, and rapid ventricular rate. Okay, these are the olol. No, okay, and and specifically we have the metoprolol and atenolol with a dosage of 5 milligrams in slow IV push. Okay, all right. Metoprolol okay, is more common than atenolol. Okay, all right. So aside from metoprolol, we also have the esmolol, yan. Okay, propanolol. Okay, right. Asong ulol, jowa mong ulol. Joke lang. Okay. All right. Okay. Now, you have to watch out for the blood pressure. Okay, when before giving the metoprolol, kasi again, metoprolol is also for hypertension. Okay, so it can there's a possibility that it can drop, no, okay, the blood pressure. Okay, all right, okay. So these are okay the medications, okay, or anti-dysrhythmia medications for the narrow QRS, okay, tachycardias. Okay, we have the adenosine, we have the calcium channel blockers, and we have the beta blockers. No, all right. Now, okay, for the wide QRS tachycardia naman, okay, for VTAC, we have the procainamide, na initially. But however, here in the Philippines, we do not have a procainamide. I just don't know the reason, okay, why. Pero okay, ever since I conduct lectures, no, in ACLS, okay, in all parts of the Philippines, wala pa akong nakitang procainamide sa mga hospitals. All right, but yes, no, it is available abroad. But if you go abroad, okay, you can encounter the procainamide, and it must be given in infusion. Okay, 20 milligrams per minute, no, IV infusion, or 100 milligrams, no. Okay, all right. Amiodarone, okay, is the most common medications that can be given in all types of tachydysrhythmias. Okay? So pwede siya sa both narrow and wide, regular and irregular QRS tachycardia. Okay? So lahat na, no? Okay, ng tachydysrhythmias. Okay? Or the dysrhythmias with a rapid rate. Okay? But then again, it cannot be given to a slow, no? Okay? Brady dysrhythmias. Okay? All right. For the YQRS tachycardia, okay, it can be, or for all, okay, types of the dysrhythmias, okay, the loading dose is 150 milligrams, okay, IV bolus, no, over 10 minutes. Ito medyo matagal-tagal, and you must follow, okay, the 10-minute IV administration of the amiodarone, okay, and it can be repeated after every 10 minutes, okay. All right. It has a slow effect, all right, okay, compared to the calcium channel blockers, but or it's not the first choice, okay, of medication, okay, for the narrow QRS tachycardia. Okay, however, ito yung pinakamura, all right, okay, and it can also, okay, result to hypotension and slow heart rate. Now, when given, okay, in very rapid administration, okay. All right. The cumulative dose, okay, of amiodarone is 2.2 grams. No, cumulative dose, okay, means the maximum dose or amount of medication that the person or the patient must take, no, okay, for 24 hours. Okay, and that is 2.2 grams. Okay, so ang ginagawa ng ibang doctors, okay, after giving the 150 milligrams, okay, they give the 2.2 grams minus the 150 milligrams, no, by infusion, okay, for 24 hours, no. Okay, so it depends on their computation. Okay, kaya nakakakita tayo ng side drip, no, na amiodarone. All right. Okay. For pedia, okay, we have 5 milligrams per kilogram IV or IO. Okay. All right. Maximum single dose of 300 milligrams. Okay. By the way, guys, no, okay, for pediatrics, no, okay, there are two most common dysrhythmias. Okay. The SVT and the VTAC, or the monomorphic ventricular tachycardia. Okay. All right. Yun lang dalawa na yun ang most common. Okay. But there is a chance, okay, that there are different types, okay, that can be precipitated, okay, but the most common are the two. Okay, all right. For cardiac arrest, nang binibigay din ang amiodarone. Okay, how? Okay, during the refractory shockable rhythm. Okay, you have to remember this, no? Refractory shockable rhythm. Okay, a refractory shockable rhythm, okay, is the shockable rhythms or the persistent shockable rhythm after 3 shocks. No? All right? We can give the 300 milligrams, no, of IV bolus, okay, of amiodarone. Okay? Ito, rapid na, no? Okay, yung administration natin kasi wala naman talagang pulse, no? Or unconscious naman yung pasyente. All right? Okay, we do not need to fear, okay, the hypotension. Okay? All right. So after 5 minutes, okay, you can give the 150 milligram. Okay? If the shockable rhythm is still refractory or persistent. Okay? All right. Another medication is the vasopressin. I would just like to mention the vasopressin. Okay, before 2015, okay, the vasopressin is given, no, during the cold resuscitation. Okay, it is given, okay, as one-time dose of 40 units. Okay, via IV in replacement of the first or the second dose of epinephrine. Okay. But according to the 2015 guidelines, okay, the vasopressin is or has no significant effect, okay, for the survival of the patient. So, bakit pa daw ibibigay kung the same lang sila ng effect ng epinephrine? Kaya tinanggal na si vasopressin. Right? Okay. Lidocaine is another medication, okay, for stable monomorphic ventricular tachycardia, and if the amiodarone is not available, quote unquote. Okay. All right. So therefore, okay, the lidocaine is not the first line of treatment. Okay. So we have to consider first the amiodarone. Right? Eh, hindi naman nawawala sa amiodarone, no? I'm sure meron kayo niyan sa e-cart nyo kasi ito yung pinakamura, no? Okay? The amiodarone. Okay? But if ever, okay, nawala, naubos, you can give the lidocaine. All right. Again, that is indicated for stable monomorphic ventricular tachycardia. All right. And okay, for the different premature contraction. Okay. All right. Okay, the dosage, okay, of lidocaine is 1 to 1.5 milligrams, okay, per kilogram. Okay, and can be repeated, okay, after 5 to 10 minutes, 0.5 to 0.75 milligram per kilogram. Okay. It can also be given, okay, through infusion or by infusion or side drip, no? Okay, just like amiodarone, with a cumulative dose of 3 milligrams per kilogram. All right. It can also be given, okay, endotrachely. Okay, you just have to double the dose, 2 to 3 milligrams, okay, per kilograms. Okay. All right, and the last medication is the magnesium sulfate. Okay, and this is specifically, okay, for tersa de poix. No? Okay, again, tersa de poix is a form, okay, of polymorphic ventricular tachycardia, okay, with prolonged QT interval. Okay, huwag nyo na intindihin yung prolonged QT interval, pang intermediate na yan. Okay, all right. So when we say polymorphic VTAC with prolonged QT interval, that is tersa de poix. Right, and the magnesium sulfate is specifically given to tersa de poix only, no, in during these arrhythmias. Okay, if the tersa de poix is pulseless, you can give 1 to 2 grams diluted in 10 ml of the 5 water IV push. But if the patient, no, is with pulse, no, or if, for example, conscious yung pasyente, okay, you have to give the 1 to 2 grams diluted in 50 to 100 respectively, okay, over 15 minutes, medyo matagal-tagal. No? Okay, kasi medyo mahapdi daw yan and medyo mainit, no, sa katawan. Okay? All right? Okay? According to the preeclampsia patient, no? Kasi it is also given to preeclampsia. Okay? All right, for pediatrics, no, okay, the dosage is 25 to 50 milligrams per kilograms over 10 to 20 minutes. Okay? So mas tagal, no? Okay? For pedia. All right. Use with caution in the following situation for patients who are receiving digitalis. One of the examples of digitalis is digoxin. Okay, digoxin can prolong the QT interval. Okay, so ibig sabihin it can precipitate, okay, the ventricular fibrillation. No, okay, it is excreted, okay, through the kidney, of course. No, okay, so if there is a renal impairment, okay, it is contraindicated. All right. Okay. Now, guys, you have to consider all anti-dysrhythmia medication as pro-arrhythmic medication. When we're talking about pro-arrhythmic medication, okay, the medication that can precipitate, no, okay, different types of dysrhythmia. Okay, so you have to give the medications with caution, okay, and with consideration. Just like uh, uh, the overdosage, okay, uh, the mode of administration or the way we administer the medication. Yeah, okay, yeah. All right. So do you have any questions with regards to the pharmacological therapy? Yan, dumami na pala tayo, no? Walang question? Or may question? Any clarification? Wala. Okay. So let me have thumbs up, guys. Ayan. Thank you very much. So, Pangila. Ayan. What about the others? Wala. Ayan. Wala yung iba. No? Okay. Let's continue with the electrical therapy para at least magkasunod, no? Okay, yung therapies natin. Okay? All right, again, okay, we have three therapies, no? Okay, in ACLS, okay, we have the mechanical therapy, we have the pharmacological therapy, and we have the electrical therapy. Okay, so the electrical therapy is the administration of electrical shock. Okay, all right. Okay, before, okay, the electrical therapy, okay, was just a defibrillation. Okay, but uh, since the year 2000, okay, they developed the cardioversion. Okay, so we already have two types, okay, of the electrical therapy, the defibrillation and the cardioversion. Okay, but let me first discuss the defibrillation. Okay, all right, the defibrillation is the delivery of an electrical current across the heart muscle over a very brief period to terminate an abnormal heart rhythm. Okay, all right. So the way the defibrillation treat the dysrhythmia is by termination, okay, or by terminating, okay, the current abnormal rhythm. Okay, for example, there is a ventricular fibrillation. Okay, right. What the electrical shock, okay, can do is to stop, okay, the pacemakers resulting to the ventricular fibrillation. Okay, right? Kasi these pacemakers, okay, overdrive suppress the SA node. So by terminating these pacemakers, okay, there is a possibility, okay, that the SA node can generate impulses, no? Okay, of course, normally. All right, okay, but that is not 100%, no? Okay, all right. Sometimes, no, um, one of the factors is the CPR, the immediate CPR, kasi if there is still a ventricular fibrillation or shockable rhythm, okay, ibig sabihin, okay, bago pa lang, no, yung sudden cardiac arrest. Okay, so the muscles of the or the tissues, okay, of the heart, okay, are not necrotic, no, still. Okay, but after 10 minutes, okay, na walang CPR, right, the tissues, okay, of or the myocardial tissues, okay, uh, uh, will die, no, okay, or due to the loss, no, okay, of the oxygenated circulating blood. Okay, so kasamang mamamatay or kasamang magne-necrosis, okay, is the pacemakers. Okay, so pag hindi tayo nakapag CPR, no, okay, immediately, there will be no circulation in the myocardial tissue. Okay, so even if we try, okay, to defibrillate the patient, okay, wala ring mangyayari. All right? Okay. So there should be an early CPR and defibrillation, okay? Right after the early recognition, okay, of the cardiac arrest, okay? Specifically the sudden cardiac arrest, okay? All right. Now, okay, we have two means, okay, to give or two ways, okay, to give the defibrillation. Okay, we have the through manual defibrillation, okay, and automated external defibrillation. Okay, we've already discussed the AED yesterday, okay? Today, okay, we will discuss the manual defibrillation. Okay, all right. This is an example of a manual defibrillator. Okay, we also have different brands, okay, of the manual defibrillator machine. Okay, but there is also no, okay, a universal or standard operating procedure. Okay, all you need to do is to know, okay, and familiarize yourselves, okay, for the most common no keys no, and buttons no, okay, of the manual defibrillator. All right, okay. Um, in the keys okay, of the defibrillator machine, okay, you can also observe or encounter okay, the numbers no 1, 2, 3. Okay, the number one okay, is the power on button, of course, no, just like any other machine. Okay, you have to turn the machine on. Okay, the second is you have to select the energy level. Okay, so using the energy select button. Okay, in other machines, okay, it is not a button, no, it is a dial, no, ibig sabihin pipihitin mo, no, okay, in order for you to select the energy level. Okay, so here no in excuse me, the energy select button, we have the arrow up and arrow down, okay, to select different energies or different levels, no, kasi we have different levels, no, okay, in response to the different types of dysrhythmias. Okay, all right, so right after we select the energy level, okay, we have to push the charge button, okay, for the machine to be charged. All right, for the conversion okay, of the energy to joules. Now, joules no, is our unit of measurement. Okay, that is watts per second square. No? Okay, so ibig sabihin, okay, from watts na kinukuha natin okay, from the direct current, it will be converted to joules. Okay, and that is specifically okay, for the treatment of the ventricular fibrillation in response to the electrical activity of the heart. Okay, all right. Ano ba ba? Okay, all right. You have to familiarize okay, yourselves okay, sa ginagamit nyong defibrillator machine sa hospital nyo. Kasi when you, there are machines that when you push the charge button, okay, differ, no, okay, from different defibrillator machine. Okay? May iba na when you push the charge button, there will be a tone, increasing tone. Okay? And when the machine is already charged, there will be an intermittent tone. Okay? May iba naman nagsasalita lang. No? Okay? For example, you push the charge button, sabihin niya charging. Okay? Then, pag naka-charge na, charge. No? Yun yung sabihin niya. Okay? Alright, so you have to familiarize. Okay? Alright, now, after charging, you have to clear, okay, the teammates, okay, for touching the patient. Okay, so you have to say, clear the patient. I'm clear. Are you clear? Yan. Okay, so um, after that, you have to locate, no, okay, the or position, okay, the manual paddle, no, if you are using the manual paddle, no, like this, okay, to a specific location, no, okay, in the patient's on the patient's chest. All right, before you push the shock button. If you use the manual handheld paddle, okay, the shock button is located above okay, the handheld. No? Okay, both paddles no, okay, have the shock button, but you have to push both no, simultaneously. Okay, if you just push the other one, okay, there will be no release of electrical shock. Okay, all right. There are machines that can be used with an adhesive pad. No? And this is more recommended okay, than the manual paddle kasi when you use the adhesive pads, no, okay, it is already in place no, every time you give okay, the electrical shock. No? Unlike the manual paddle, you have to position every time you give the electrical shock. Okay? All right? Okay. If you are using the adhesive pads, okay, the shock button is located here, no, or somewhere, no, okay, in the uh, keys, no, okay, of the machine, okay, with a lightning icon. All right. There are also manual defibrillator machine, okay, that can be converted to AED. Okay, just like this live pack, no, okay, 20. Okay, this can be uh, converted to AED, na aside from manual defibrillator machine. Okay, kaya pwedeng siyang bitbitin, okay, sa ambulance. Alright? Okay? And paliitan na ngayon, okay, ng manual defibrillator machine. Okay? Di tulad dati, no? Okay, na sobrang laki. All right. Okay. Other considerations, okay, for the defibrillation, okay, is the phase, no? Before before 2005, okay, we have the monophasic defibrillation only. Okay, ibig sabihin nun, okay, the release, okay, of the electrical shock, okay, is by one pad only. All right? Okay, just like what you can see na in your screen. Okay? The release of electrical shock is through one the other pad only, no? Okay? And it will go to, or it will enter, okay, the next pad. Okay? All right. And that is the reason why we have to follow, okay, the recommended position. Okay? This is the recommended position again, okay? Below the right collarbone beside the sternum over the nipple. Okay? And lower on the left few inches below the armpit over the ribs. Okay? So that the heart becomes the center of the two pads. For the electrical shock to pass through the heart, okay, to terminate the abnormal rhythm. Okay, so if you position, okay, the pads lower than recommended, the heart will not become the center of the two pads, so therefore there will be no effective, there will be no termination, okay, of the abnormal rhythm. Okay, all right. Until 2005, okay, the monophasic, okay, is changed, no, or was changed to biphasic. No, kasi according to their studies, okay, the biphasic defibrillation is more effective, okay, to terminate the abnormal rhythm than the monophasic. So ever since, okay, or since then, okay, the manufacturing, okay, of the defibrillator machine, okay, is biphasic already. Okay? So lahat ng monophasic na phase out na, okay, or the machines are converted to biphasic defibrillation. So nako-convert naman yung luma. Okay? All right. Okay, there are times that the electrical shock, no, okay, is impede, no, ibig sabihin kay nababawasan, no, due to the resistance to the flow of current, no, and we have the transthoracic impedance, the natural resistance to the chest wall. Okay, these are the skin surface, okay, fat, the bone, and the hair. The hair can be an impedance if it delays, okay, the defibrillation. Okay, if the patient has an excessive chest hair, we have to shave the part. Okay, if it can delay, okay, the defibrillation, okay, you have to use the manual paddle. All right, okay, para wala nang shaving. Okay, the bone is the number one impedance. That is the reason why we do not place the pads or the paddle on the sternum. Okay, right? Kasi there will be a large amount, okay, of the electrical energy that will impede by the breastbone. Okay, right. The fat can be an impedance, okay, if the pads is placed over the breast. Okay, lalong-lalo na kung Susan, no, okay, yung pasyente. Okay, medyo makapal yung tissue, no. Okay, right. So the conduction, okay, of the electrical shock will be delayed or impede. Skin surface can be an impedance kung merong mga nakadikit-dikit, no, okay, or may damit, no, okay, doon sa skin surface. Okay, so we have to remove, no, okay, all those unnecessary materials. Okay, all right. Now, you have to consider the paddle size, no? Okay, for infant, okay, we have the infant size, okay, or okay, for a patient, okay, who weigh more than or less than 10 kilograms, we have to use the small size or the infant size. Okay, but if the patient is greater than, okay, 10 kilograms or 22 pounds, okay, or generally more than 1 year, 1 year old, okay, we can use the adult size. Okay, all right, but depende, no? Okay, Filipino size, okay, kahit 1 year, more than 1 year or 2 years old, okay, medyo maliit pa yon. Okay, so you have to consider the infant size. Okay, all right. No skin preparation, okay, is considered. Okay, so wala kang ipapahid or i-apply, okay, over the skin, okay, of the patient. Okay, all right. You have to use the conductive material, okay, over the metal plate of the handheld paddle, okay, to promote the conduction and to prevent the burn, okay, of the skin. Okay, kasi we are talking about kuryente, no? Okay. I had an experience before, okay, that my colleague, no, administer a defibrillation, okay, to a patient without conductive material or even lubricating gel, no, over the metal plate of the handheld paddle. So ang nangyari, sunog, no, yung balat. Okay? All right? So nagreklamo yung pasyente. Doon namatay yung pasyente, kaya lang sunog pa rin, no? Okay? right? Yung balat, no, ng patient. Okay? All right, so you have to be very careful with that. All right. And you have to know, okay, how to select the energy level. Okay? All right. We have two types of electrical therapy, the synchronized and unsynchronized. Right? Pag sinabi natin na unsynchronized, that is defibrillation. Right? And it is indicated for shockable rhythms. Now, we have just two shockable rhythms. Okay? We have the ventricular fibrillation and pulseless ventricular tachycardia. All right? Okay. Now, when we say unsynchronized, okay, we do not have to consider anything, okay, before we give the electrical shock, okay? Just select the energy level, position the pad, okay, and push the shock button. Okay, once you push the shock button, the electrical shock will be delivered, right? Okay, but when we're talking about synchronized cardioversion, okay, we have to attach the patient, okay, to the defibrillator machine. Okay, all right. So what the synchronized cardioversion can do, okay, is first the defibrillator machine will synchronize with the ventricular activity of the patient. Okay, so that when we push the electrical shock, okay, the electrical shock, or once we push, okay, the shock button, the electrical shock, okay, will time, okay, to occur during ventricular depolarization to limit, okay, to limit the termination of other pacemakers that can generate impulses normally. All right? Okay. So sa madaling salita, okay, the cardioversion must only be indicated, okay, for tachydysrhythmias with pulse. Okay? All right? Specifically, SVT with pulse, AFib, A-flutter, and RVR with pulse, and ventricular tachycardia with pulse. Okay? All right? Okay. If accidentally, okay, we give, okay, cardioversion to patient without pulse, okay, there will be no release of electrical shock kasi, okay, the machine may not be able to identify any ventricular activity. Okay? But if you administer, okay, the defibrillation, okay, to patient, no, with pulse, no, okay, that is supposedly, okay, be given with cardioversion, mapapatay natin yung pasyente kasi or the defibrillation can stop, no, or terminate all the uh, functional pacemaker, right? Okay. Energy level, okay, for the defibrillation, okay, again, for pulseless ventricular tachycardia and or ventricular fibrillation, and even, okay, to polymorphic ventricular tachycardia with or without pulse, okay, we give 120 to 200 joules, okay? Huwag niyo naintindihin yung monophasic na to, no? Okay, kasi mayroon tayong variation, no? Okay, if the machine is monophasic, 360. But if the machine is biphasic, 120 to 200 joules kasi wala naman na yata ngayong monophasic. Lahat biphasic na. All right. Okay, so this is a range, okay, of the energy level, 120 to 200 joules. So you have to know, okay, the increment, okay, of your machine. There are machines that has an increment of, for example, 100, okay, then 125, tapos 150, 175, I guess, then 200. Yeah, no? But there are machines now from 100, 150 agad. Okay? Okay, so if that's the case, okay, you have to choose the 150, okay, initially. Do not use the 100 kasi that is smaller than the recommended dose. Okay? Or you can just start, okay, with 200 joules, no? Okay? All right, basta this is a range, no? 120 to 200 joules. You can start, no? Okay, from 120 to 200. But always consider an increase, okay, of energy level on the next defibrillation. Okay? All right? For the cardioversion, okay, for SVT, you have 50 to 100 joules. Unstable atrial flutter, you have 50 to 100 joules. Unstable atrial fibrillation, you have 120 to 200 joules. And unstable monomorphic ventricular tachycardia, 100 joules. Again, you have to increase, no, okay, in stepwise fashion if the initial shock fails. Ibig sabihin, on the next cardioversion, you have to increase the energy level, okay, from, okay, the next increment of your machine. Okay? All right? Okay, now, For the cardioversion consideration, okay, you have to push the sync button first. SYNC button. Okay, all right. For example, no, okay, the machine is already turned on. Okay, the machine is already connected to the patient. Okay, and this is our tracing. This is a ventricular tachycardia. The patient is with pulse. Okay, all right. You have to look for the SYNC button. This is a synchronized button. Okay, so ibig sabihin, when you push this, okay, the machine will automatically synchronize. Okay, the or synchronize with the activity of the heart. Okay, all right. Then you select the energy level. Okay, for example, 100 joules. Okay, and you lastly, you can push the shock button. Okay, that is the same. Okay, with defibrillation. Okay, the only difference is in defibrillation we do not push the sync button. Okay, that is the difference. Okay, all right. You need to consider sedating the patient before giving. Okay, the cardioversion. Okay, kasi mararamdaman ng patient yan. Kuryente, masakit yan. Okay, all right. Okay, so you have to wait for the patient to be sedated, to become sedated before you give the cardioversion. Okay, all right. Now, right after the cardioversion, you have to check the pulse of the patient. Okay. Kasi pag nawala ng pulse yan, okay, and this can happen, no? Pag nawala ng pulse, you have to provide CPR. All right? Okay. Now, there's a difference, okay, when checking for the pulse, okay, in defibrillation and cardioversion. Okay, again, in cardioversion, right after the delivery of the shock, you have to check for the pulse. No, in defibrillation, right after administering the shock, you have to perform or provide CPR. No need to check for the pulse. Okay, clear? All right. Any question, guys? Any question? Okay, please turn on your cam. Guys, yeah. Thank you very much. No? Sarap ng kinakain ni Maribel. Duty ka, Maribel? Kasi naka-white ka eh. From duty. Okay. Hi, Sir Joselito. Yan. Okay. Christine Joy. Yan. Good morning. Okay. All right. Do you have any questions with regards to our therapy, pharmacological therapy, and electrical therapy? Wala? Thumbs up naman, guys. Okay. Kung walang question. For those who are not opening their cam, yan. Okay. Baka ayaw nyo magpakita. Then hindi pa naliligo. Okay. All right. Okay, let's have our 10-minute break. Okay, for this morning. Okay, my time is 9:21. Okay, we will resume at 9:30. Okay. All right. With algorithm discussion. Okay. All right. Okay. So 10-minute break. kinakausap ako? Thumbs up, guys. Yan, thank you very much. Oh, wala pa yung iba. Iilan lang. Okay. Okay. Thank you. Okay. We have 4 algorithms. Okay. In dysrhythmias. Okay. The tachydysrhythmia with pulse algorithm, the bradycardia with pulse algorithm, okay, the cardiac arrest algorithm, and the immediate post-cardiac arrest care algorithm. Okay, so the algorithms, okay, are followed if we have these arrhythmias, no? Okay, specifically, okay, for example, no, okay, you assess the patient has a tachydysrhythmia. Okay, we will follow the tachycardia with pulse algorithm, and okay, the same with bradycardia and cardiac arrest. Okay, all right. So the management, okay, for the dysrhythmias are, let's say, scripted. Yeah, no, okay. This is one of the examples of clinical practice guidelines, okay, that the clinical or the medical practitioners, no, is following. All right. Okay, for the standards, no? Okay? Lahat ng medical professionals, okay, are following different standards, no? Okay? Based on their discipline. Okay, for example, no? Okay, before ang hirap i-treat ng dengue, no? Maraming mataas ang mortality. Okay? But the WHO, okay, found ways, okay, to treat, okay, the dengue, okay, by means of the studies, no? Okay, so they release, no, okay, the clinical practice guidelines, okay, for the medical practitioner to follow the standards, okay, to manage the dengue, no? Okay, until then, mas madali na lang natin na manage, no, yung dengue. All right, okay, all right. Now, just like in tachydysrhythmias, okay, you will never go wrong, okay, with the management of the patient, okay, if you follow, okay, the algorithms. Okay, these are set, okay, of step-by-step processes, no, okay, to manage the patient in different types of these treatments. Okay, all right, let's start, okay, with the bradycardia with pulse algorithm. Kaya meron siyang with pulse kasi kung walang pulse, ang tachy and brady, okay, it means PEA. Okay, so sa ang algorithm tayo pupunta? Sa cardiac arrest, okay, kung walang pulse. Alright? Okay, but if you determine that the patient has a pulse or still conscious, okay, then we have to follow with pulse algorithm. Okay, alright, now. Okay, the secondary survey or the secondary assessment, okay, is for advanced cardiac life support. Okay, the primary survey or primary assessment is for the basic life support. Okay, the difference of the two, okay, is the primary survey, okay, is just to obtain the presence or the absence, okay, of the response, okay, the breathing and the pulse immediately, right, for us to perform, okay, for us to provide, okay, the CPR immediately. Okay, but if the patient is still conscious, okay, we will not proceed to the next step of the primary survey. Okay, what we do, okay, or what we should do, okay, is what we should perform, okay, is the secondary assessment. Okay, or let's say, for example, the patient is unconscious. Okay, when you check for the response, suddenly the patient is gumising. Okay, right, and of course, okay, obviously the patient has a pulse and breathing. All right. Okay, so the secondary survey, okay, is to assess for the quality, okay, of the status of the patient. No, all right. Initially, okay, by obtaining the vital signs. All right. Okay. So initially, okay, after we check for the response of the patient, okay, and the patient is responsive, okay, we have to obtain the vital signs. Okay. You have to follow the ABCD pa rin. Okay. Right. Airway and breathing. The checking for the response is one of the ways to check for the open airway of the patient. If the patient is conscious, nagsasalita, no, okay, definitely the airway is open. But if the patient is unconscious, again, lying supine, okay, the back of the tongue may block the airway. All right, so you have to proceed, okay, with the um, checking for the breathing and pulse. Okay, all right. Now, if the patient is conscious, we have to check, okay, for the breathing. All right, the uh, if the patient is complaining of the difficulty of breathing, okay, or if there is an irregularity of the breathing pattern of the patient, okay, then proceed to the circulation. Okay, you check for the pulse, right? If the pulse, okay, is more than 100, okay, and that we have to follow the tachycardia with pulse algorithm. But if the patient has a slow heart rate, you have to follow the bradycardia with pulse algorithm. Okay. All right. Another circulation assessment, okay. By the way, for the breathing pala muna tayo, no? Okay. You have to check also, okay, for the oxygen saturation of the patient. Okay. All right. Okay. Circulation, okay. You have to check aside from pulse and the quality of pulse, you have to check for the blood pressure of the patient. Okay. All right. And of course, disability. Okay. That is in trauma cases. All right. Okay. Now, after obtaining the vital signs, okay, you have to proceed to the second box. Okay. This is to identify and treat underlying cause. Okay. This has something to do, okay, with the initial findings, okay, that we obtain, okay, from the vital signs. Okay. For example, okay, the patient has no patent airway, okay, due to the unconsciousness, okay, or unresponsiveness. Okay, then we have to find ways, okay, to assist the patient. For example, okay, we can assist the breathing, okay, of the patient, okay, through the different devices, okay, or the use of bag valve mask, okay, or we can give oxygen therapy if the oxygen saturation is below the normal, okay, which is the 95 to 100 normal. Okay, all right, we have to attach the patient to the cardiac monitor to identify, okay, the specific dysrhythmia that is causing different signs and symptoms. Okay, and of course the blood pressure also. All right, now after treating, okay, this underlying cause, okay, you have to proceed to the third box. Okay, all right, the third box is the determination of the status of the patient. Okay, if the answer is no, okay, then the patient is still stable. If the answer is yes, the patient is already unstable. Okay, all right, so you have to answer these, no? Okay, HASYA, no? Okay, mnemonics. Okay, hypotension, acute altered mental status, signs of shock, ischemic chest discomfort, acute heart failure. Okay, if there is even one, no, uh, in this HASYA, okay, that is present, okay, the answer is yes. Okay, for example, yung check nyo yung blood pressure, there is hypotension, okay, with a systolic blood pressure of 80, no, and below. Okay, the answer is yes. Okay, then the patient is already unstable. Okay, clear? All right. If the patient is still stable, we just have to monitor and observe. In bradycardia, ha? Kasi magbabago yan kapag nasa tachydysrhythmia na tayo. Okay? Alright, but if the patient is unstable, okay, you can give the atropine sulfate. Alright? Okay, so ganun lang kadali. All you need to do, okay, is to check for the status of the patient every now and then, okay, to know, okay, the necessary management. Okay? Alright. Since the atropine sulfate, okay, has an interval, the administration of atropine sulfate has an interval of 3 to 5 minutes, you have to reassess the patient every 3 minutes, okay, in order for you to check, no, okay, whether the first dose changes, okay, the status of the patient. Okay, if from previous assessment the patient is become stable, you do not need to give, okay, the next dose of atropine. Okay, clear? Right? But if there is a persistent bradydysrhythmia and the patient is still unstable, you have to give the succeeding doses, okay, of atropine sulfate. Okay, clear? All right. Now, okay, for the bradycardia with pulse algorithm, okay, For the tachycardia with pulse algorithm naman, kay medyo nagbago siya na when it comes to the status of the patient. Okay? The same kay with the assessment, the same with the identifying and treating underlying cause, and the same with the third box, okay, the determination of the status. Okay? But this time, okay, if the answer is yes, okay, unstable na daw, okay, yung pasyente, you have to give synchronized cardioversion. Okay? If the patient is still stable, the answer is no. Okay, from okay, the question here on the third box. Okay, you have to consider medications. Okay, all right. The medications are divided into two. Okay, for narrow QRS and for wide QRS. Okay, kasi magtatanong dito sa box na to. Okay, wide QRS daw ba? If the answer is yes, that is VTAC, no? Okay, this is the management. Okay, and for the narrow QRS, the answer is no. Okay, this is the management. Okay, we've already discussed the management. Okay, for wide QRS, ventricular tachycardia, okay, we have the procainamide, okay, and we have the uh, amiodarone or the lidocaine or the magnesium sulfate. Okay, for the narrow QRS, okay, we have the adenosine, okay, we have the calcium channel blockers, and we have the beta blockers. Okay, all right. You can see the vagal maneuvers here. No? Okay, the vagal maneuver, okay, is the stimulation of the vagus nerve. Okay, all right. Through for example, advising the patient to cough, okay, to squat, no, okay, to gag, okay, application of cold stimulus to the extremities, and okay, the most common is the carotid massage. Okay, all right. So you have to locate the carotid pulse, no, and massage, no, okay, the area. Okay, it can slow down the heart rate temporarily, all right, while waiting for the medication, okay, to be administered. All right. Okay. By the way, guys, now in pregnancy, okay, the first trimester and in the first trimester, okay, of pregnancy, okay, there should be no anti-disease treatment medications. Okay, only the lidocaine can be given, no, okay, safely. Okay, so what we do, okay, is a palliative management. Okay, we manage the signs and symptoms, okay, of the patient, okay, and the carotid massage. All right, kasi it can cause miscarriage. Okay, all right. Now, okay, if ever, okay, the patient, okay, is in cardiac arrest. Okay, for example, let's have a scenario. No, you're about to check the vital signs, okay, of the patient. No, in a private room. Okay, once you enter the room, the patient is asleep or seems asleep. Okay, all right. When you wake the patient up, the patient cannot able to wake up. Right, so ibig sabihin, the patient is unconscious. Okay, so you have to proceed to breathing and pulse. Okay, if the patient has no breathing and has no pulse, okay, call for help, and that is the activation of the code blue. Okay, this is the part. Now shout for help and activate the emergency response. All right. Okay, guys. No. Okay. Please always wake the patient up. No. Okay, when obtaining vital signs. Okay. For example, every 4 hours, even during wee times, no, okay, or madaling araw na, you have to wake the patient up, no. So this is one of the ways, okay, to check, okay, whether the patient is unconscious or not. Okay, baka hindi nyo ginising yung pasyente, okay, from 10 p.m. okay, to 6 a.m. Nanigas na pala kasi nag-cardiac arrest na pala nung madaling araw. All right, okay. Okay, even if the patient is requesting na huwag siyang gigisingin, no? Or huwag mag-check ng vital signs, huwag kayong papayag, no? Kasi the patient is your liability, no? If the order is every 4 hours, no? Okay, vital signs, you have to check, okay, for the status of the patient every 4 hours. So gigisingin natin siya. Okay, clear? All right. So let's say for example, no, the patient is in cardiac arrest. Okay, you have to activate the code blue, okay, and return to the patient to start the CPR. Okay, all right. This time, okay, wala kang ibang gagawin kung hindi mag-compress. All right? Okay? And wait for the team members to arrive. All right? So the team members, the standard team members, okay, for the code resuscitation, okay, are the compressor, the airway, or responsible for the ventilation, okay, the medication nurse responsible for the administration of the medication, obtaining the IV line. Okay, the electrical therapist, okay, the responsible for the operation of the defibrillation or the manual defibrillator machine. The documentation nurse, okay, responsible for, of course, for the documentation and for the time. Okay, uh, for to this person is responsible for the awareness of the group, okay, for the next dose, okay, of any medication, and for the timing of the CPR, okay, and of course the team leader. All right, in other institution, okay, the team leader, okay, is aside from the ROD or the doctor, okay, uh, counterpart for nurses is the charge nurse or the head nurse. Okay, so he or she oversees the performance of the group, no, okay, and of course the correct uh, dosage, no, and administration of the medication. Okay, all right. Okay, so once the members or the team arrives, there should be someone who should assign, or the team leader should assign, okay, the roles. Okay, or kaya naman alam nyo na dapat, no? Okay, yung pupuntahan nyo. Okay, all right? And primarily, okay, there should be someone, okay, to ventilate the patient. Okay, all right? When this happens, okay, there should be a collaboration, okay, with the compression, okay, or the compressor. Okay, kailangan gawin nyo na yung 30:2. Kasi from the beginning or at first, you are just doing the compression only CPR, right? Okay, but once that the members arrive, okay, there should be someone, okay, who should give the ventilation, okay, and okay, the 30:2 must be followed. Clear? All right, and there should be someone, okay, who should immediately attach the patient to the cardiac monitor, okay, for us to know, okay, if there is a dysrhythmia causing the arrest. All right, kasi we have to immediately, okay, give the necessary management, okay, for that shockable rhythm. Okay, all right. Now, once the patient is connected, okay, to the defibrillator machine, okay, and there is an electrical activity in the cardiac monitor, okay, we have to stop, okay, the the CPR, okay, and analyze the rhythm. Okay, all right. You have to determine if the rhythm is shockable or non-shockable. Okay, if non-shockable, okay, expect asystole or PEA. Okay, right? Ventricular fibrillation or pulsus ventricular tachycardia naman, okay, kapag shockable rhythm. Okay, all right. Now, okay, if the patient, okay, has a non-shockable rhythm, you have to immediately resume the CPR and give the epinephrine immediately if there is already an IV line. All right? Okay. But if the patient, okay, has a shockable rhythm, okay, you have to deliver the shock immediately. Okay? All right? Okay, right after the delivery of the shock, okay, you have to perform or you have to provide the CPR, right? Okay, that is for 2 minutes. Again, okay, the 5 cycles of CPR is equivalent to 2 minutes. Okay? All right. Now, if the patient is already, or if the patient is in ICU, okay, with endotracheal tube already, okay, you do not need to do the 5 cycles of CPR with a ratio of 30:2. Okay? The compression, okay, should be continuous, no, for 2 minutes. Okay? At and yung imo-monitor ng documentation nurse. Okay? Siya yung magsasabi na 2 minutes na. Okay? All right? Again, okay? Magkaiba, okay, ang CPR natin, okay, if the patient has no endotracheal tube and if the patient has an endotracheal tube. Okay? If the patient has no endotracheal tube, the CPR remains 30:2. Okay? For 5 cycles, that is equivalent to 2 minutes. Okay? But if the patient, okay, has an endotracheal tube already, the compression must be continuous, okay, for 2 minutes. The ventilation, okay, through bag through bag resuscitator, okay, connected to the endotracheal tube, okay, must be continuous also for 2 minutes with an interval of 6 seconds. Right? Maliwanag yun, ha? Alright. Okay. This time, wala muna tayong ibibigay na medication. Okay? Unlike if the patient is non-shockable. Okay? All right. So we will wait, okay, for another 2 minutes, okay, or 5 cycles, okay, before we check for the pulse again, okay, and determine if the rhythm is shockable or non-shockable. Okay? If the rhythm is still shockable, okay, we shock the patient, okay, and right after the shock, okay, we provide CPR. Okay? Ito na, dito na tayo. Okay, we provide CPR. Okay, then right after the second shock, you when during, okay, the CPR, you give the epinephrine. Okay, and that is automatically 3 to 5 minutes, every 3 to 5 minutes. Okay, all right. This time, you can consider an advanced airway kung wala pang endotracheal tube. Okay? But make sure that the endotracheal tube insertion, okay, will not compromise the cycle of the CPR or the process of CPR. Okay? Kasi ang pinakamahalaga during code blue, okay, is the CPR. Okay? Over, okay, the intubation. Okay? All right. Now, okay, the perfect timing, okay, of intubation, okay, is when there is already an ROSC or the return of spontaneous circulation para hindi ma-compromise ang CPR. Right? However, here in the Philippines, inuuna ang intubation. Okay? Which is wrong. Right? Alam niyo naman dito sa Philippines, no? Ang tradisyon, ang nakagawian, ang hirap baliin. Alright, anyhow, okay, alright, this is the standard, pero kung yun ang ginagawa nyo sa hospital, okay, sumunod na lang kayo kay team leader. Alright? Okay? Okay, but make sure, if I were you, no, if I'm the one doing the CPR, pag pinahinto ako, hindi ako hihinto. Okay, kasi alam ko ang standard is the continuous CPR. Okay? Alright, anyway. Okay, let us suppose hindi mo na tayo nag-intubate. Okay, continue natin yung process. Okay? Alright, after 5 cycles ulit, okay, you have to stop your compression, check for the pulse, no, and check for the rhythm. If the rhythm is still shockable, okay, you have to shock. Meron bang limitation ang pag-shock natin? Wala po, no? Okay? As long as there is a shockable rhythm, shock lang tayo na shock. But, no, okay, the shockable rhythm kasi, okay, will not last long, no? Okay? Usually, okay, less than 10 minutes lang talaga, okay, or even 5 to 8 minutes lang, no, okay, according to the studies. Okay, all right. So right after the delivery of the third shock, okay, and the shockable rhythm is persistent, it is considered to be a refractory shockable rhythm. Okay, anong bibigay nating medication for refractory shockable rhythm? That is amiodarone, okay, 300 milligrams. Okay, all right. Now, we will continue the process. Okay, paulit-ulit lang yan. Kaya babalik na lang tayo ulit dito, no? Okay, sa checking for the pulse and checking for the shockable rhythm. Okay, again, if the answer is yes, shockable rhythm, okay, paulit-ulit nyo lang yang gagawin. All right? With the consideration of the interval time, okay, of the medication, ha? Okay? All right. Now, but if the patient, okay, is already non-shockable with pulse, non-shockable muna, okay, you have to proceed to the box number 12. Okay? All right? It says here that if no signs of return of spontaneous circulation, wala raw pulse, okay, you have to proceed to 10 or 11. 10 or 11. Okay? This is another process, okay, of the repetitive CPR and administration of epinephrine. Okay? But if the patient, okay, has a pulse, okay, go to post-cardiac arrest care. Okay, this time, if the patient has already a pulse, okay, you are through. Okay, tapos na kayo, okay, sa cardiac arrest. All right? Okay, now, okay, what you should follow is the immediate post-cardiac arrest care. Okay? All right. Since we already have a pulse, or the patient already has a pulse, okay, we have to prioritize now the airway and breathing. Okay, kaya on the second box, okay, we have to optimize the ventilation and oxygenation. Okay, you have to maintain oxygen saturation of 94%. Okay, all right. If the patient has no spontaneous breathing, and we have to consider advanced airway insertion or endotracheal tube insertion. This is the perfect timing, okay, for the insertion of the endotracheal tube. But if the patient, no, has a spontaneous breathing right after, okay, the resuscitation, with the oxygen saturation of normal, no need, okay, for intubation. But it is rarely happen. Okay? It can rarely happen. No? It can happen na kapag naagapan natin, no, yung cardiac arrest. No, it can happen. All right? Okay. Now, while optimizing the ventilation or while someone is doing the intubation, you have to check for the blood pressure. This is the circulation now. Okay? If you do not treat the hypotension, okay, magka-cardiac arrest ulit yung pasyente. And this time, it is due, okay, to the hypotension. Okay? All right. So you have to treat the hypotension by means of IV bolus, okay, or vasopressor infusion. Vasopressors, okay, are the epinephrine or epinephrine, okay, or the dopamine. Okay? All right? All right. So now, okay, once we stabilize the blood pressure, okay, and the patient is already, okay, with advanced airway, we have to know, okay, if the patient can follow command. Okay? Why do we need to do this? Okay? To determine, okay, if there is a significant uh, affectation, okay, in the brain tissue. If the patient is in comatose, okay, then the brain tissues, okay, are affected, okay, by the loss of oxygen. Okay? But if the patient can follow command, okay, by simply bubulungan nyo lang yung pasyente, instruct the patient if he or she can squeeze your hand, okay, or can raise the hands or part of the body, okay, then the patient is not in comatose. All right? Okay. So the patient can be managed, okay, by different irreversible causes. Okay? Ibig sabihin, if the patient is can follow command, okay, mas madali nating mamamanage ang patient kasi the cause, okay, is reversible. Okay? All right. So these are the reversible causes of cardiac arrest. Okay? Hypovolemia, hypoxia, hydrogen ion, hyperkalemia, hypothermia, tension pneumothorax, tamponade or cardiac tamponade, toxins, pulmonary thrombosis, and coronary thrombosis. Okay? All right. How would you know, okay, the reversible causes? Okay, by facilitation of the different diagnostic procedures. So for example, radiography, CT scan, arterial blood gas, no, laboratory test, no, okay, yeah, no, ultrasound, no, okay, yeah, no, history also, okay. All right, we can able to identify the reversible causes. But if the patient, no, okay, is not responding, okay, we have to start inducing hypothermia. Okay, this principle is decreasing the core body temperature, okay, to slow down the deterioration of the brain tissue. Okay, all right. Later, okay, I will be playing the resuscitation video, okay, and there will be an explanation of induced hypothermia. Okay, all right. Now, this box, okay, is the identification, okay, of the reversible cause, no? Okay, the cardiac catheterization laboratory is not constant, no? Okay, the reason why they put here, okay, or the cardiac catheterization laboratory, okay, is it's just an example, okay? If the patient has a coronary thrombosis, okay, so you have to send the patient to cardiac laboratory, okay. All right. Okay, so this part is for the determination of the reversible causes of cardiac arrest. Okay. All right. Then, okay, while we are treating the patient, okay, for reversible causes, okay, we have to transfer the patient to advanced critical care. Okay, and tapos na yung role natin. Sila na ang problema doon sa intensive care. Okay. However, okay, should follow. They should still follow, okay, the algorithms, okay, when there is a recurrence, no, okay, or another precipitation of any type of dysrhythmia. Okay. All right. Question, okay, for the algorithms before we play the video, okay, of the code resuscitation. Question? Question po, wala? Okay, this video is from American Heart Association. Okay, and we use this, okay, for the or as an example, okay, of code resuscitation. Okay, actually, guys, no, okay, when if we have a face-to-face classroom type training, okay, the algorithms, okay, are the standards that you will follow for your return demonstration. Okay? Kaya lang wala tayong return demonstration, no? Okay, sa mga panahong to. Okay? So basically speaking, mahirap no magiging return demonstration. Okay? Kasi you have to identify what type of dysrhythmia, okay, the patient has, okay? Plus the management, okay, through the algorithms, no? Okay? So literally, okay, bubuhay kayo ng pasyente, okay? Kaya lang, walang ganon. Kaya video na lang tayo. Okay? Alright. So this video okay, is a perfect example okay, of a code resuscitation. Okay? That is followed actually no? Okay, abroad. No? Okay? In Middle East, in Western countries. Si Pinas lang naman talaga ang matigas ang ulo pagdating sa standards. Alright. Let me know okay if there are problems no okay with regards to the audiovisual presentation. Message the concern.
Team dynamics are critical during a resuscitation attempt. The interaction among team members has a profound impact on the effectiveness of each individual as well as the patient's overall survival. The better you work as a team, the better the potential outcome for your patient. That's why it's so important that you understand not just what to do in a resuscitation attempt, but how to communicate and perform as an effective team, regardless of your role as team member or team leader. Welcome to the American Heart Association's Megacode and Team Resuscitation video. In this video, we're going to demonstrate and model an effective resuscitation team in a case scenario. Our simulation will have 6 team members. You may have fewer members depending on the situation, so be prepared to adjust your roles accordingly. Our case study begins in a local emergency department, where a 65-year-old woman has been brought in complaining of epigastric and back discomfort.
Hello, I'm Dr. Jackson. What's bothering you today?
Oh, doctor, I don't feel good. I feel really bad. I'm dizzy and I'm sick at my stomach. My son was really worried about me and he brought me in.
Okay, are you having chest pain right now?
No, but I'm hurting. It started in my stomach and now it's in my back.
Okay, we're gonna see if we can find out what's going on, okay? Joette, do we have a set of vitals from Ms. Fernandez?
Yeah, blood pressure is
For a moment, guys, no?
Team dynamics are critical during a resuscitation attempt. The interaction among team members has a profound impact on the effectiveness of each individual as well as the patient's overall survival. The better you work as a team, the better the potential outcome for your patient. That's why it's so important that you understand not just what to do in a resuscitation attempt, but how to communicate and perform as an effective team, regardless of your role as team member or team leader. Welcome to the American Heart Association's Megacode and Team Resuscitation video. In this video, we're going to demonstrate and model an effective resuscitation team in a case scenario. Our simulation will have 6 team members. You may have fewer members depending on the situation, so be prepared to adjust your roles accordingly. Our case study begins in a local emergency department, where a 65-year-old woman has been brought in complaining of epigastric and back discomfort.
Hello, I'm Dr. Jackson. What's bothering you today?
Oh, doctor, I don't feel good. I feel really bad. I'm dizzy and I'm sick at my stomach. My son was really worried about me and he brought me in.
Okay, are you having chest pain right now?
No, but I'm hurting. It started in my stomach and now it's in my back.
Okay, we're gonna see if we can find out what's going on, okay? Joette, do we have a set of vitals from Ms. Fernandez?
Yeah, blood pressure is 70/40, heart rate is 45 beats per minute, respiratory rate is 16 breaths per minute, and pulse ox is 92%.
Okay, let's go ahead and start her on 2 liters of O2. Ms. Fernandez, we've got you hooked up to a monitor so we can take a look at your heart rhythm, okay? And we've started you on oxygen so you can breathe a little easier.
Your pulse ox reading is 95% with 2 liters of O2.
Oh,
Okay.
oh, doctor. Oh, doctor. I feel really dizzy.
Okay, it looks like we have sinus bradycardia. Dana, let's go ahead and get an IV started right now.
Miss Fernandez, Mrs. Fernandez, can you hear me? Mrs. Fernandez. She's unresponsive.
I don't feel a pulse.
Okay, let's call a code. The patient's gone into VFib. Start chest compressions.
Starting compressions.
Mandel, you'll be on defibrillator. Shelley, you'll be recording.
Recording.
Sam, you'll manage the airway. Dana, have you been able to establish an IV access yet?
I've tried several times, but it's failed.
Okay, let's move on to IO access, please.
Moving to IO access.
24, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Charging at 200 joules. Shock ready, clear the patient. Shocking on 3. 1, 2, 3, shocking. Shock delivered.
I have IO access now.
Great. We'll continue CPR for 2 minutes and evaluate the need for additional defibrillation. Shelley, I'll rely on you to monitor the quality of the chest compressions. Dana, you'll need to draw the drugs up before each rhythm check, so if the arrest persists, we can move quickly to drug therapy. Let's begin with 1 milligram of epinephrine.
Drawing 1 milligram epinephrine.
2 minutes.
Okay, let's analyze. Switch roles. Okay, the patient remains in VFib. The protocol for this biphasic device is escalated dosing. Let's shock again at 300 joules.
Shocking at 300 joules. Charging. Clear the patient. Shocking on 3. 1, 2, 3. Shocking. Shock delivered.
Continue CPR.
Continuing compressions. 1, 2, 3.
Dana, please give 1 milligram of epinephrine.
1 milligram epinephrine. And the IO is flushed.
Great. We've given 2 shocks and given 1 milligram of epinephrine. The next medication to consider is amiodarone. Dana, please prepare 300 milligrams of amiodarone.
Drawing 300 milligrams of amiodarone.
Sam, are you getting good chest rise?
Yes, and I'm being careful not to deliver ventilations too quickly or forcefully.
Okay, great. Let's continue there.
2 minutes.
Okay, let's analyze. Switch roles. Okay, the patient is in persistent VF. Let's shock again at 360 joules.
Charging at 360 joules. Shock ready, clear the patient. Shocking on 3. 1, 2, 3, shocking. Shock delivered.
Continue CPR.
Continuing CPR. 1, 2, 3, 4.
We can give amiodarone now?
Thanks, Shelley. Dana, please give 300 milligrams of amiodarone.
Okay. 300 milligrams of amiodarone given. And the IO is flushed.
We've given 3 shocks. After the second shock, we administered 1 milligram of epinephrine, and we've just given 300 milligrams of amiodarone. Our next drug will be vasopressin. Dana, please prepare 40 units of vasopressin.
Drawing 40 units of vasopressin.
12, 13, 14, 15, 16, 17, 18, 19.
Let's review any reversible causes by considering the H's and T's.
What about hypovolemia?
That's a good thought. We have IO access established, but no obvious signs of internal or external bleeding. Anybody else have any other suggestions?
Have we considered hypoxia?
Is the airway still patent?
Still getting good chest rise.
She came in with epigastric discomfort and symptomatic bradycardia. Have we considered coronary thrombosis?
That's a great point. Everything seems to suggest a STEMI.
2 minutes.
Okay, let's analyze, switch roles. Okay, the monitor shows sinus bradycardia. Do we have a pulse?
I don't feel a pulse.
Continue chest compressions.
Continuing chest compressions. 1, 2, 3.
Shelley, how long has it been since our last dose of epinephrine?
3 minutes.
Okay, Dana, let's go ahead and give 40 units of vasopressin.
40 units of vasopressin given. And the IO is flushed.
Mandel, your compressions are slowing down. Can you pick up the pace a bit? 2 minutes.
Let's analyze, switch roles. Okay, the monitor shows sinus tachycardia. Sam, do we have a pulse?
I can feel a rapid, weak pulse.
Okay, great. Let's initiate immediate post-cardiac arrest care. Dana, let's get a blood pressure, a complete set of vital signs, pulse ox, and labs. Mandel, let's start a 12-lead ECG, please. Can we check to see if this patient is breathing and responsive?
Ma'am, can you squeeze my fingers? She's still unresponsive.
Still not breathing.
Okay, let's insert an advanced airway and prepare for therapeutic hypothermia.
The patient's blood pressure is 82/40 with a heart rate of 130 and a rhythm of sinus tachycardia.
Okay, the patient is hypotensive. Let's start with a liter of saline. Since we've started with hypothermia, let's use cold saline for the bolus.
Okay, we'll switch out for cold saline.
Tubes in.
Okay, we've got good breath sounds. Let's establish waveform capnography. The O2 saturation is 96%.
Here's the 12 lead.
Okay, she has a STEMI. Mandel, please call the cath lab and tell them that we have a STEMI patient. PCI and hypothermia can be safely combined after cardiac arrest.
The return of spontaneous circulation, or ROSC, is no longer the end of the cardiac arrest protocol. More scientific studies show that survival rates improve significantly with a comprehensive system of post-cardiac arrest care.
It is important to know your local system's plan for the management of post-cardiac arrest patients. Hypothermia is the only intervention that has been shown to improve neurologic recovery. The resuscitation team should consider inducing hypothermia for any patient who remains comatose after ROSC. Several studies show improved outcomes for patients whose bodies were cooled to 32 to 34 degrees Celsius for 12 to 24 hours.
A new recommendation in the 2010 guidelines is the introduction of a structured team debriefing. Studies show teams who debrief together perform better on subsequent codes. Here's how team debriefing differs from simple feedback. Feedback is geared toward correcting actions. Effective debriefing focuses on correcting the thought process that leads to the action. While debriefing takes longer than simple feedback, it results in deeper understanding. The hallmark of structured debriefing is a learner-centered self-analysis and active participation in discussion. The goal is to gather information on how the code progressed, to analyze the information, to create an accurate record, and to summarize the goals for future improvement.
Thanks, team. Nice job. I made a few notes during my evaluation, so let's talk about what went well and why you made the decisions that you made.
Well, from my perspective, I thought the code went very well. Shelley did a good job monitoring the quality of chest compressions. Shelley, did we have any prolonged pauses or interruptions in the chest compressions?
No, Joette and Mandel both switched positions quickly and resumed compressions, even as the defibrillator was charging.
Mandel, did you get tired or have any trouble with the pace of compressions?
At the end of the code, I was starting to slow down, but Shelley was able to correct the rate of compression, so I was able to pick up the pace. It is easy to lose track of how fast you should be compressing, so having someone pacing you through the code is helpful.
Yeah, maybe we should use a metronome to help keep pace or make it standard practice to do compression checks at points during the code.
Yeah, that's a good idea. Let's try that next time. Sam, what do you think of managing the arrest without an advanced airway?
We were getting good chest rise the entire time, so we didn't need to interrupt chest compressions to insert an endotracheal tube.
You know, we could have inserted a supraglottic airway. That could have been done without interrupting the chest compressions.
You know, that could have been an option, especially if ventilations became too difficult. One benefit of using a bag mask ventilation is that ventilations are at regular intervals, and it kept me from ventilating too much. However, because she wasn't intubated, we didn't have end-tidal CO2 readings to monitor CPR quality or detect ROSC.
Yeah, that's a good observation. It is a trade-off when to consider inserting an advanced airway. Yeah. Dana, how did you feel about your treatment, especially moving to IO access early in the code?
IO access in adults is new to me, but I found that it was easy to push drugs through.
So, what are the take-home messages?
I thought it was great that we assigned code team roles early in the day, because when the code was called, I knew exactly what I was supposed to do.
Yeah, because before we did that, we'd walk into a room and there'd be some confusion.
Good. Anything else? Okay, again, nice job.
Successful teams not only have medical expertise and mastery of resuscitation skills, they also practice good communication skills and adhere to the key elements of effective team dynamics. These elements help teams work together in the most efficient way possible. Let's review those now. Closed-loop communication. This is important for both the team leader and team members. When the team leader gives an order, the team member should confirm that he or she heard and understood the order. The team leader should make sure the team member understood the order before assigning additional tasks. Clear messages. Using concise, clear language helps prevent misunderstandings. Speaking in a tone of voice that is loud enough to understand, but also calm and confident, helps keep all team members focused on the task at hand. Clear roles and responsibilities. When everyone knows their job and responsibilities during a code, the team functions smoothly. The team leader should clearly define and delegate tasks according to each team member's area of competence. Know your limitations. Every member on the team should know his or her limitations, and the team leader should be aware of them. Ask for assistance and advice early, not when the situation deteriorates. Knowledge sharing. This is a critical component of effective team performance. Team leaders should ask for good ideas for a differential diagnosis and frequently ask for observations from team members about possible oversights. Constructive intervention. Now, sometimes a team member or the team leader may correct actions that are incorrect or inappropriate. It's important to be tactful, especially if you have to correct a colleague who is about to make a mistake, whether it's a drug, dosage, or intervention. Summarizing and reevaluation. Summarizing information out loud is a good way to maintain an ongoing record of treatment and acts as a way to reevaluate the patient's status, the interventions performed, and where the team is within the algorithm of care. This technique can also help team members respond to the patient's changing condition. Finally, all team members should display mutual respect and a professional attitude to other team members, regardless of their personal expertise or training. It's important that the team leaders speak in a friendly, controlled voice, avoiding shouting or unnecessary aggression. Not only is it important to know what to do during a MegaCode event, it's as important to know how to work together as a team during the code. Reviewing how a code went not only helps individual team members perform better in subsequent codes, but may also bring system deficiencies to light. Now we'll play the MegaCode resuscitation case study again. This time, as you watch, look for the key elements of effective team dynamics. Closed-loop communication, clear messages, clear roles and responsibilities, knowing one's limitations, knowledge sharing, constructive intervention, summarizing and reevaluation, and mutual respect.
The patient's gone into VFib. Start chest compressions.
Starting compressions.
Mandel, you'll be on defibrillator. Shelley, you'll be recording.
Recording.
Sam, you'll manage the airway. Dana, have you been able to establish an IV access yet?
I've tried several times, but it's failed.
Okay, let's move on to IO access, please.
Moving to IO access.
24, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Charging at 200 joules. Shock ready, clear the patient. Shocking on 3. 1, 2, 3, shocking. Shock delivered.
I have IO now.
Great. We'll continue CPR. Drug therapy. Let's begin with 1 milligram of epinephrine.
Drawing 1 milligram.
Isolated dosing. Let's shock again at 300 joules.
Shocking at 300 joules. Charging. Clear the patient. Shocking on 3. 1, 2, 3. Shocking. Shock delivered.
Continue CPR.
Continue compressions. 1, 2, 3.
Dana, please give 1 milligram of epinephrine.
1 milligram epinephrine. And the IO is flushed.
Great. We've given 2 shocks and given 1 milligram of epinephrine. The next medication to consider is amiodarone. Dana, please prepare 300 milligrams of amiodarone.
Drawing 300 milligrams of amiodarone.
Sam, are you getting good chest rise?
Yes, and I'm being careful not to deliver ventilations too quickly or forcefully.
Okay, great. Let's continue there.
2 minutes.
Okay, let's analyze, switch roles. Okay, the patient is in persistent VF. Let's shock again at 360 joules.
Charging at 360 joules. Shock ready, clear the patient. Shocking on 3. 1, 2, 3, shocking. Shock delivered.
Continue CPR.
Continuing CPR. 1, 2, 3, 4.
We can give amiodarone now.
Thanks, Shelley. Dana, please give 300 milligrams of amiodarone.
Okay. 300 milligrams of amiodarone given. And the IO is flushed.
We've given 3 shocks. After the second shock, we administered 1 milligram of epinephrine, and we've just given 300 milligrams of amiodarone. Our next drug will be vasopressin. Dana, please prepare 40 units of vasopressin.
Drawing 40 units of vasopressin.
12, 13, 14, 15, 16, 17, 18, 19.
Let's review any reversible causes by considering the H's and T's.
What about hypovolemia?
That's a good thought. We have IO access established, but no obvious signs of internal or external bleeding. Anybody else have any other suggestions?
Have we considered hypoxia?
Is the airway still patent?
Still getting good chest rise.
She came in with epigastric discomfort and symptomatic bradycardia. Have we considered coronary thrombosis?
That's a great point. Everything seems to suggest a STEMI.
2 minutes.
Okay, let's analyze, switch roles. Okay, the monitor shows sinus bradycardia. Do we have a pulse?
I don't feel a pulse.
Continue chest compressions.
Continuing chest compressions. 1, 2, 3.
Shelley, how long has it been since our last dose of epinephrine?
3 minutes.
Okay, Dana, let's go ahead and give 40 units of vasopressin.
40 units of vasopressin given. And the IO is flushed.
Mandel, your compressions are slowing down. Can you pick up the pace a bit? 2 minutes.
Let's analyze, switch roles. Okay, the monitor shows sinus tachycardia. Sam, do we have a pulse?
I can feel a rapid, weak pulse.
Okay, great. Let's initiate immediate post-cardiac arrest care. Dana, let's get a blood pressure, a complete set of vital signs, pulse ox, and labs. Mandel, let's start a 12-lead ECG, please. Can we check to see if this patient is breathing and responsive?
Ma'am, can you squeeze my fingers? She's still unresponsive.
Still not breathing.
Okay, let's insert an advanced airway and prepare for therapeutic hypothermia.
The patient's blood pressure is 82/40 with a heart rate of 130 and a rhythm of sinus tachycardia.
Okay, the patient is hypotensive. Let's start with a liter of saline. Since we've started with hypothermia, let's use cold saline for the bolus.
Okay, we'll switch out for cold saline.
Tubes in.
Okay, we've got good breath sounds. Let's establish waveform capnography. The O2 saturation is 96%.
Here's the 12 lead.
Okay, she has a STEMI. Mandel, please call the cath lab and tell them that we have a STEMI patient. PCI and hypothermia can be safely combined after cardiac arrest.
In this section of the course, we've shown you the key steps involved in the adult cardiac arrest algorithm, as well as the post-cardiac care algorithm, to promote a positive patient outcome in the event of the return of spontaneous circulation. You've also evaluated the megacode scenario with the key elements of effective team dynamics and structured team debriefing. Combining your knowledge of essential arrest skills with effective team dynamics can give your team a better chance of success with every resuscitation attempt.
Okay, guys. Okay, do you have any question? A question? In the video, okay, meron pa silang vasopressin, no? Okay, pero of course, no, as I've mentioned, okay, tinanggal na natin 'yon in 2020. Okay? All right? May question ba? Wala. Okay, let's have 10-minute break, no? Okay, again, okay? My time is 10:27. Okay, we will resume at 10:37. Okay? All right. There also, no? Can I have a thumbs up, no? Okay, para at least alam ko lang na nandyan kayo. Okay, 4. 4 pa lang. 5. 6. All right. Okay, the next topic that we have is the acute coronary syndrome. All right. Again, okay, the acute coronary syndrome is another cause, okay, of the cardiovascular compromise, okay, that can be also manageable. However, okay, the management, okay, for the ACS is very technical, no? Okay, more of the doctors, okay. But for nurses, okay, it's very important for you, okay, to know how to refer the patient, no? Okay, using the 12-lead ECG, okay, for the acute coronary syndrome determination, and of course, at least you know, okay, the common primary care intervention ng acute coronary syndrome. All right? All right. The acute coronary syndrome, okay, is or are distinct conditions, okay, that are caused by a similar sequence of pathologic events and that involve a temporary or permanent blockage of coronary artery. Okay, so it has something to do with the flow, okay, or alteration of the flow of the oxygenated blood, no, okay, into the myocardial tissue. Okay, it's okay, from the plaque deposit, or a permanent blockage caused by a thrombus, no, okay, from other parts of the body blocking, okay, the part of the coronary arterial system. Okay, all right. There is a sequence of events, okay, that can occur, okay, during acute coronary syndrome, and these are the ischemia, injury, and the necrosis. Okay. All right, so we will have a comparison later on, no, and the different presentation that can be observed, no, okay, in the 12-lead ECG. Okay, all right. There are two pathologies. There are two pathologies that can be associated, okay, with the development, okay, of the acute coronary syndrome, and these pathologies, okay, are the arteriosclerosis, no, and the atherosclerosis. Okay, arteriosclerosis is a chronic disease of arterial system, okay, that is characterized by the abnormal thickening and hardening of the blood vessel wall. Now, as we age, okay, there is an arteriosclerosis. Okay, the atherosclerosis is a form of blood or the blood vessel wall thickening, okay, that are caused by build up of fat like deposits deposits, no? Okay, okay, so this is an example, okay, of a plaque deposit, no? Okay, that can, okay, narrows down, okay, the flow, okay, of the oxygenated blood. Okay, all right. Okay, this plaque deposit can be a thrombus, no? All right. However, okay, we have two types, okay, of thrombus formation. Okay, we have stable and vulnerable. The stable plaque, okay, are the thick cup, no? Okay, that has a low tendency, okay, to rupture or erode, no? While the vulnerable plaque, okay, are the type of plaque that has a thin cap of fibrous tissues that can separate, okay, from the wall, okay, of the blood vessel wall, okay, when there is an increased flow of blood, no? Okay, so during the increased pressure, okay, of blood flow, okay, this plaque, no, can rupture, no, and can be, okay, a cause of a blockage. All right. Okay. The rupture of vulnerable plaque may occur, okay, after the following, okay, extreme physical activity, okay, especially, okay, if you are unaccustomed, okay, to regular exercise, okay. For example, okay, from or since birth, no, okay, hindi ka nag-exercise, no, okay, and then until you reach the 40, you decided to have some physical activity, okay, you have to consult your cardiologist, no, kasi to test, no, if there is a risk, no, na magkaroon ka ng rupture of the plaque. Okay? All right. Severe emotional trauma, no, can also be a cause. No? Okay? That is the reason why kapag masama ang loob mo, okay, sumasakit ang dibdib mo. Okay? Kasi there is sometimes, okay, a vasoconstriction, okay, or okay, if you have an existing plaque deposit at nag-vasoconstrict pa yung blood vessel mo, okay, there will be a narrowing, okay, of the blood vessel, okay, resulting to the decreased oxygenated blood flow. Sexual activity, okay, kasi lahat ng system mo gumagana, no? Exposure to illicit drugs, especially the cocaine and amphetamines, okay, this can be caused by the trauma, okay, of the blood vessel wall. Okay, so if there's a trauma of the blood vessel wall, there will be an accumulation of the different factors, okay, that can be resulting to a deposit, no? Okay, within the blood vessel wall. Okay, exposure to cold due to the vasoconstriction and acute infection. Okay, specifically the strep, no? Okay, infection. Okay, all right. Okay, the strep infection can go down, okay, to the valve, okay, of the heart. Okay, it can rupture, okay, the valves, okay, and can be a thrombus, no? Okay, if erodes, no, okay, from the original position. Okay, all right. The most common area, okay, of the plaque disruption, okay, is or can occur, okay, at the vessel bifurcation. Okay, specifically, okay, the bifurcation, okay, from the left main coronary artery here, okay, to the circumflex artery at the side and the anterior descending artery. Okay, so dito nangyayari sometimes, no? Right? Okay, if this happens, okay, the extent of damage case is large enough, okay, to stop, okay, the function of the heart. Okay, so imagine, no, okay, if there is a blockage, no, okay, at the left main coronary artery, the anterior, the septum, and the lateral, and a portion of the posterior wall, no, will be affected, okay, by the injury. All right, so therefore, okay, there will be left-sided heart failure, okay, or the worst is, okay, if the whole left ventricle or the left part of the heart, no, okay, is affected, okay, by necrosis, okay, it will not be stimulated anymore, it will not contract now anymore, right? Kaya diyan nangyayari yung heart attack, no, okay, during sleeping, right? Okay. Okay, we have three categories, okay, of acute coronary syndrome. Okay, the general term, okay, for the MI is acute coronary syndrome. Okay, it's either unstable angina and STEMI or STEMI. So we have to know, okay, the consideration of each, no, okay, before we diagnose, no, okay, the categories. All right. Okay. The most common sign of the acute coronary syndrome is, of course, angina pectoris. It's about 80 to 90% of patient experiencing acute coronary syndrome has an angina pectoris. Angina pectoris is a chest discomfort, no? Or other related symptoms caused by myocardial ischemia. So when there is ischemia, there will be an angina pectoris that can be experienced by the patient right after the decrease of blood flow, right? Okay, and these are the descriptions that a patient can subjectively give to you, right? These are the common sites, right? Okay, now if the patient is 40 years old and above and there is an abdominal pain, it is a protocol in emergency room that the 12-lead ECG must be obtained, due to the epigastric consideration or epigastric pain or discomfort consideration. It's also it's a common NCLEX question. No, all right. So it doesn't mean that even if you do not have any chest discomfort, you are or there is no cardiac in origin. All right. So the 12-lead ECG is a very reliable source of information for the acute coronary syndrome. All right. The myocardial ischemia is an imbalance between the metabolic needs of the myocardium and the flow of oxygenated blood. The ischemia is primarily caused by the decrease level of oxygen flowing in the myocardial tissue, caused by initially the narrowing of the blood vessel wall due to the or related to the plaque deposit. All right. Okay. There are acute ischemia and there are chronic ischemia. All right. The chronic ischemia can be experienced by the patient with most commonly diabetes, kasi there are buildup of plaque, doon sa or within the coronary arterial system. So sometimes matagal na pala siyang nakaka-experience ng angina pectoris pero tinitiis lang niya. But it doesn't mean na merong complete blockage. All right? Okay, now the angina is can be stable or can be unstable. All right. If the patient is or if the angina is unstable, it is most likely related to a cardiac origin. If the angina pectoris is stable, it may be due to the precipitating events. For example, emotional upset, exercise or exertion, exposure to cold weather. All right. The angina pectoris happens within this event, or can be precipitated by this event. But when you take a rest, nawawala yung angina. All right. Compare to the unstable angina, it happens or the symptoms will occur at rest, and that usually lasts for more than 20 minutes. A consistent pain. Symptoms that are severe or of a new onset, for example, or especially within the last 2 months, and symptoms that are increasing in duration, frequency, or both, and intensity in a patient with history of stable angina. Right. So if you experience an angina pectoris during or at rest, it is probably an acute coronary syndrome. All right. However, the clinical presentation in ECG and ECG findings of unstable angina, and acute MI may be identical. Acute MI is the injury, all right, and that is the STEMI, or ST segment elevation myocardial infarction. It can be identical, from unstable angina. However, when the angina pectoris subsides, hindi na nakakaramdam ng angina pectoris yung patient, the presentation in the ECG may return to normal. So there's no way for us to identify if that is STEMI or NSTEMI. All right. So that's how we categorize the unstable angina. If there is a history of angina pectoris at rest, and there is no presentation in the ECG, right after the resolution of the signs and symptoms, Okay, that is unstable angina. Okay, all right. Okay, now, the ischemia that is prolonged by more than just a few minutes results in myocardial injury. Okay, but from ischemia to injury, okay, they are still manageable. Okay, all right. But no, okay, after few minutes or after a few moments, okay, if the injury is not resolved, I mean managed, okay, the cut-off of blood, okay, or the severe reduction, okay, in the blood oxygen supply, okay, will lead to necrosis. Okay, all right, and that is what we call the infarction. Okay, all right. The necrotic muscle, okay, or tissue of the heart, okay, may not be able to be stimulated by electrical impulse. So imagine, no, a left ventricle, okay, that is not depolarizing, okay, it will not contract, therefore it will not pump blood into the circulation. Okay, however, okay, we have the necrosis depends on the layer, no, okay, it is affected. Okay, right, it's either subendocardial, okay, etong nasa loob lang, okay, or can be subepicardial, yung nasa labas, or the worst is transmural. Okay? Intramural yung nasa gitna, no? Okay? The worst is the transmural, okay? From the inside to outside. Okay? All right. If the necrosis no happens, okay, to be in the or along the subendocardial only, okay? The other layers, okay, will be depolarized, no? Okay, still. Okay? However, okay, the heart, okay, may not be able to tolerate, okay, the fraction of the contraction. Kaya nagkakaroon din sometimes ng heart failure, okay, ng decreased ejection fraction, okay, ng different complications or problems with the heart. Okay? All right. Now, to categorize, okay, further, okay, the acute coronary syndrome, aside from the unstable angina, okay, you have to assess for the ST segment. Okay? All right? Okay? It's either the there is an elevation, okay, or a depression, okay, of the ST segment. Okay, all right, this is a normal ST segment. Okay, you have to um, you have to measure, okay, the ST segment that must be along the isoelectric line. Okay, all right, if this segment, okay, elevates or depressed, okay, it means acute coronary syndrome. Okay, all right, so the measurement for the ST segment is for the elevation, okay, there must be 2 millimeters and above, no, elevation, okay, to consider an acute coronary syndrome. For the depression naman, okay, there must be 1 millimeter and above, no, depression. Okay, all right, the normal is, again, okay, it must be along the isoelectric line. All right, okay, so you have to draw an imaginary line. All right, okay, so these are the examples, no, okay, of the different ST segment. All right, the letter A example is normal, okay, kasi this is your ST segment. Okay, all right, if you draw an imaginary line, okay, for with the isoelectric line, it is along the isoelectric line. Okay, all right, the letter B is a normal ST segment also, no, okay, this is your isoelectric line and this is your ST segment. Okay, all right, this is an example of an elevated ST segment. Okay, this is your isoelectric, sorry, hirap mag-draw ng line. Okay, this is your eye. Hindi ko ma-straight. Yan. Okay, for example, yan na lang, no? Okay, this is your isoelectric line, okay? And this is your T wave, actually. Okay? If there is a peak T wave, okay, actually it indicates acute, no, ischemia. Okay? A peak T wave, right? So sometimes, okay, the ST segment, okay, will or the peaking of the T wave, okay, during the ischemia and injury, okay, will carry the elevation, okay, of the ST segment. Okay, kaya the ST segment is somewhere here. Okay, yan. Okay, elevated pa rin siya. Okay? All right, and this is more commonly or most commonly, no, okay, happening in the V1 to V6 leads. All right. Letter D, okay, is also an elevation. Okay, this is the isoelectric line. Okay, this is your ST segment. Okay, this is your T wave. Okay, all right. So there is a 2, no, okay, millimeter and above elevation. Okay, all right. The letter E, okay, is an example. You have to focus on this, guys, kasi mamaya, okay, you will identify an example, okay, of an acute coronary syndrome. Okay, sasagutin nyo yun. Letter E is also an example, okay, of an elevation. This is the isoelectric line. Yeah, okay, all right. This is your ST segment. Okay, letter F is a depression. Okay, this is your isoelectric line. Okay, this is your ST segment. Okay. All right. Letter G, okay, is also a depression. Okay, and also the letter H, also a depression. Okay, this is your T wave inverted. By the way, guys, if sometimes, okay, the T wave will become negative in deflection, okay, if there is an ST segment depression. Okay. All right. Yeah. Okay. Now, if you observe an ST segment elevation, okay, the category of the ACS is ST segment elevation myocardial infarction. Okay. But if you observe a depression, okay, without an elevation, okay, the category is NSTEMI, non-ST segment elevation myocardial infarction. Okay, all right. So that is how we categorize, okay, the 3 acute coronary syndrome. Okay, again, okay, for unstable angina, okay, there is no presentation, okay, in the 12-lead ECG, okay, but the history, speaks itself. Okay, in STEMI there are depression. Okay, in STEMI there are elevation. Okay, all right. Now the 12-lead ECG, okay, from lead 1, lead 2, lead 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. Okay, okay, is a reference, okay, of a different area, okay, of the heart. Okay, all right. The use of the 12-lead ECG for identifying the acute coronary, not only identifying the acute coronary syndrome, okay, but for locating also the site, okay, of the affected area. Okay, all right. You have to know, okay, the group of leads, no, okay, representing the different parts of the heart. Okay, the lead 2, the lead 3, and the lead AVF, no, can see the inferior wall. No, ito yung inferior wall. Okay, right? So if you see an elevation at leads 2, 3, and AVF, okay, your diagnosis would be STEMI inferior wall. Okay, all right? So laging ganon, no? Okay, may the category plus the wall, right? Okay. The leads 1, AVL, V5, and V6, no, can represent or can see the lateral wall, no? Ito yon, no? Okay, so if you see elevations at lead 1, AVL, V5, V6, your diagnosis would be STEMI lateral wall, right? If the elevation is seen, okay, at leads V1 and V2, okay, STEMI septal wall, okay? In V3 and V4 naman, anterior wall. All right. Okay. If, okay, the elevations, okay, are seen at leads V1, V2, V3, and V4, pagsasamahan nyo lang si anterior and septum, anteroseptal wall. All right. If, okay, the whole chest leads, okay, the V1, V2, V3, V4, V5, and V6, okay, pagkasamahan nyo yung tatlo, anteroseptolateral wall. Okay, clear? All right. The 12-lead ECG can only, okay, see, okay, the inferior wall, okay, the lateral wall, the anterior wall, and the septal wall. Okay, it cannot see the posterior wall and the right part of the heart. However, okay, there are clues, okay, in the 12-lead ECG, okay, that can signify, okay, that there is a posterior wall and a right ventricular wall. Pero hindi na yon basic. Okay, all right. Okay, so we have 12 leads. No? Okay, again, the lead, okay, is a record of electrical activity. Okay, all right. We have 12 leads. The lead 1, okay, to lead V6, okay, the standard 12 lead ECG, okay? All right. Okay, this group of leads, no, okay, representing a part of the heart is called contiguous leads. So this is the principle. Indicative changes are significant okay, when they are seen into anatomically contiguous leads. Okay? Ibig sabihin, okay, if the 2, 3, and AVF okay, can represent the inferior wall, all of these leads okay, must have indicative changes no, okay, that can be observed. Okay? If there is only one, okay, if there is only one lead that has a presentation, okay, or a change or an observable change, okay. For example, lead to lang, no, okay, it may not become indicative, no, or significant, okay, insignificant yon. So dapat at least dalawa, no, ang meron doon sa contiguous leads, okay, all right, okay. Now, again, okay, the 2, 3, and AVF, no, okay, are the contiguous leads of the inferior wall. The leads 1, AVL, V5, and V6 are contiguous leads of the lateral wall. Okay, the leads V1, V2 are contiguous leads of septum. Okay, and the leads V3 and V4 are contiguous leads of anterior wall. The AVR okay, has no representation. Okay, all right, in standard 12 lead ECG. Clear? Question po? None. Okay. So when you have a 12 lead ECG, okay, you have to check okay the ST segment. Okay, for example, okay. All right. This is a normal, no? Okay, 12 lead ECG. Okay, why? Kasi from V1 to V6, okay, all of the ST segments are in isoelectric line. Okay? Ayan, nasa isoelectric line lahat sila. Okay? So walang problema. Okay? All right. Okay, guys. Okay, familiarize yourselves, no? Okay, doon sa appearance kay ng 12 lead ECG natin. Okay? All right. In B1, okay, we have specifically a complete set, no? Okay, of the standard waveforms, the PQRST, but sometimes in other individuals, walang Q, but it is still normal. Okay? All right. The R wave, okay, in leads 1, 2, 3, AVF, okay, must all be positive. I mean, the QRS complex must all be positive. Okay? In AVL, okay, it can either be negative, okay, or positive. Okay? Pwede. All right? Okay. In leads V1, okay, to V6, okay, as you can observe, okay, from V1, there is a very small R wave. Okay? Until V2 tumataas, V3 naging biphasic na, okay, or equal na sila. Okay, until V4, okay, mas mataas na si R wave compared to S wave, and V5 to V6. Right? This is the normal, okay? But then again, okay, the SC segment must still be in isoelectric line. Okay, clear? All right? Okay, so this is what you should identify in the examples that I will present to you. Okay, all right. Sometimes you can identify, okay, sometimes you can identify or you can observe elevations, okay, or depression. Okay, for example, now in leads 2, 3, and AVF inferior, there is an elevation. Yeah. There are elevations, okay, observable elevations, okay? And in lead 1 and AVL, meron ding depression. All right. So does it mean okay, that there is a STEMI okay, at inferior wall and an NSTEMI okay, at lateral wall? Okay? No, hindi ganun yon, no? Okay? You have to prioritize the elevation. Okay? If you can see, okay, this kind of example, no? Or this example. If you see an elevations at leads 2, 3, and AVF representing inferior wall, expect a depression, okay, at leads 1 and AVL, okay, due to the or because of the contralateral change. The inferior wall, okay, is directly perpendicular, okay, to the lateral wall, okay? So the changes, okay, must be contralateral. Okay, so ibig sabihin, okay, if there is an elevation, okay, at the inferior wall, okay, there must be a depression at the contralateral change, which is the lateral wall. The same with, if there is an elevation at the lateral wall, there must be a depression at the inferior wall. Okay, but okay, you must diagnose the elevation, not the depression. Okay, clear? But if it happens, okay, that you only see a depression, okay, your diagnosis would be NSTEMI only. Clear? All right? Wala tayong question doon? Okay, now. Okay. May question ba kayo, guys? Before we start kay the question and answer. May question ba? Thumbs up, guys. Thumbs up. Hello, guys. I hope you're still there. Okay, thank you very much. Okay, now let us see, no, okay, if you can identify, no, okay, an acute coronary syndrome here, okay, in this example. Okay, all right. Okay, so just place your answer, no, okay, in the chat box. Okay, give me the category of acute coronary syndrome, whether it is NSTEMI or STEMI, plus the wall, no, okay, it represents. Ano na, guys? Identify the leads, okay, that have presentation, okay, of acute coronary syndrome, okay, and give me the diagnosis. Joselito, okay, what is the category? You have to diagnose like this, no? The category, okay, plus the wall, no? Okay. I mean, for example, STEMI or NSTEMI plus the wall. Okay. So tingnan natin, no? Okay. We have an elevation, okay, that can be observed at leads 1, no, and AVL. Okay? All right. So tama si Celito, no? Okay? All right. And these represent the lateral wall. Okay? So that your diagnosis would be STEMI lateral wall. All right? Okay. The inferior wall, 2, 3, and AVF, okay, has an elevation, has a depression. Okay? Alright, di ba ang sabi ko kanina? Okay? If the 1 and AVL has an elevation, there must be a depression at the opposite side, which is the inferior wall, 2, 3, and AVF. Okay? You will diagnose, okay, the elevation, not the depression. Malinaw? Alright? Okay, so your diagnosis here is lateral, STEMI lateral wall. Okay? Alright. Okay, next. Next example. Okay, thank you very much, Ocelito, no? Okay, and Zyrene, okay? Yan, Christine. Okay, we have STEMI inferior wall, okay? All right, why? Kasi we have elevations that leads 2, 3, and AVF, okay? All right? Okay, next. Okay, thank you very much, Usalito. Okay, STEMI anterior wall, no? Okay, as evidenced by the elevations at lead V3 and V4. Okay, but no, okay, there is an additional, no? Okay, there is also an elevations at lead V2 and V1. Okay, so sasama natin si septum, no? All right. Okay, so the diagnosis would be STEMI anteroseptal wall. Right? Okay. Okay. All right. Now, the reasons, okay, why we have to identify, okay, the wall, okay, is for the doctor, okay, to assess, okay, for the possible complications, okay, all right. If lateral wall, okay, that is the there can be an affectation, okay, in the left ventricle, okay, so therefore the force of pumping, okay, of the blood Okay? Inferior wall naman, okay? Something to do with the part of the right ventricle. Okay? Septum, okay? Nandoon yung bundle V's and bundle branches natin. Okay? So there is a possibility na magkaroon ng bundle branches block. Right? Okay? Anterior wall, okay? It can cause tachydysrhythmias. No? Okay? Inferior wall, it can cause hypotension. Okay? All right. Okay. So that is the reason. And other than or aside, okay, from the identification, okay, of acute coronary syndrome. Okay. All right. Okay, so thank you very much, okay, for those who answers. Okay. All right. The cardiac biomarkers, okay, are the enzymes that are released, okay, by the muscles, okay, after it is being traumatized. Okay. The CKMB, CK, myoglobin, and troponins, okay, are these cardiac biomarkers. But the more specific, okay, for the myocardial tissue, okay, are the troponins I and T. Okay, these are released, okay, by the muscles, okay, or the tissues of the heart after 2 hours, okay, from the onset of the angina pectoris, right? And the peak release is 6 to 12 hours. Okay, so history is very important. Okay, before you check, no, okay, the troponins. Okay, you have to ask, no, okay, if what or when, okay, is the onset, okay, of the angina pectoris. Okay, kapag wala pang 2 hours, then it will not become elevated. Okay. All right. Okay, the initial management of ACS, of course, okay, we have the bed rest, no? Okay, in a position of comfort. Okay, wala dapat activity, okay, to minimize the load, okay, of the needed oxygen in the body. Okay. All right, assessment of the vital signs, okay, oxygen saturation, IV access, history, okay, physical examination, and of course, degree of pain. Okay, all right. Pain must be relieved kasi pain can contribute to the vasoconstriction, and kailangan nating i-minimize, no, okay, ang vasoconstriction, okay, to prevent, okay, the ischemia. Okay, all right. The management or the pharmacological therapy, okay, for the acute coronary syndrome, okay, are the analgesic, anti-ischemic, antiplatelet, thrombolytics, and fibrinolytics. Okay, so isa-isahin natin yon. Okay, anti-ischemic therapy, okay, is the nitroglycerin, okay, sublingual tablet. Okay, it relaxes the vascular smooth muscle, therefore it dilates arterial and venous vascular bed, okay, for the blood, okay, to pass through easily. All right. Maximum of 3 tablets, okay, must be consumed, okay, by the patient. Okay, if no, okay, if the angina pectoris is not relieved by the first, no, by the first tablet, no, interval of 5 minutes, okay, for a maximum of 3 tablets. Okay, all right. Analgesic, morphine sulfate, no, okay, if the pain is very severe, okay, and that's very common, okay, for the STEMI. Okay, all right. This is a potent narcotic analgesic, no, and anxiolytic. Okay, so we give 1 to 5 milligrams for unstable angina, okay, or STEMI, and 2 to 4 milligrams, okay, initially for STEMI. Okay, but the cardiologists prefer to give the minimal dose, okay, minimum sample for in unstable angina and STEMI. Okay, we give 1 milligram lang, no? Okay, and for STEMI 2 milligrams lang. Okay, right, every 5 to 50 minutes. No? Kasi the expected adverse effect, okay, that is lethal, okay, is respiratory depression. Okay, all right. Hypotension, okay, can also be an adverse effect. Okay, all right. Beta blockers, no, okay, is also given. Okay, but this is an additional medication, okay, just to prevent, okay, the tachydysrhythmia, okay, and to maintain the current normal heart rate. All right, ACE inhibitors, okay, to prevent the vasoconstriction. Okay, antiplatelet therapy, okay, aspirin, okay, for a maximum dose of 325 milligrams, okay, in emergency room. Okay, and 75 to 162 milligrams OD indefinitely. Okay, clopidogrel, okay, 75 milligrams, no, per tablet, 4 tubs maximum loading dose, no, okay, in emergency room. Okay? This antiplatelet therapy, okay, can prevent the platelet, no, okay, clumping, no, and forming clots. Okay, but it cannot dissolve, okay, the clot. All right. Uh, Glycoprotein 2B3 inhibitors, okay, it prevents the fibrinogen binding and platelet clumping. Kasi if the fibrinogen binds to platelet, it hardens kay the plaque deposit. All right, anticoagulant, okay, we have the heparin, okay, maximum of 5,000 IU, no, okay, as a loading dose in emergency room. All right, then we have the reperfusion therapy. Okay, pag sinabi natin reperfusion therapy, okay, we are prioritizing the muscle of the heart, okay, by dissolving, okay, the clot, okay, within 30 minutes of patient contact. All right. Okay, so this is through fibrinolytics. Fibrinolytics, it is a clot buster. Okay, it alters the plasmin in the body, which then breaks down fibrinogen and the platelet clots. All right. Okay. One of the examples of fibrinolytics is streptokinase, no? Okay, and a plasminogen activator, okay, or a recombinant tissue plasminogen activator. Okay. All right, medyo mahal to, no, yung mga fibrinolytics, okay? And this must be given, okay, within 30 minutes of patient contact, okay? All right. Other than pharmacological therapy, we also have invasive therapy, okay? And one of the examples of invasive therapy is the balloon insertion, okay, or the stent insertion, okay, or the angioplasty, right? Okay, there is a device, okay, a cord-like device that is inserted, no, in a femoral artery, okay, to the coronary artery of the heart, okay, with an inflatable balloon, no, at the tip, no, and a camera, okay. So kung nasaan yung bara, okay, or nasaan yung narrowing, okay, of the blood vessel, inflate nila yung balloon, okay, para ma-dilate yung blood vessel. Okay? Then the stent will be remained, no? Okay, will be retained, okay, doon sa mismong part. However, okay, medyo bumabalik yung plaque deposit, no, kapag angioplasty lang. Okay? All right? If CABG naman, coronary artery bypass graft surgery, okay, we bypass, okay, the part of the blood vessel wall that is blocked, no? We bypass this, okay, through the use of this blood vessel, which is the saphenous vein. We connect the both ends, okay, the other end, okay, from the major artery or the aorta, okay, to the distal end, okay, of the coronary artery that is not being blocked. Okay, all right. However, this is an open heart surgery, okay, so it requires a lot of money, okay, and a rehabilitation right after, okay, a few days of confinement. Okay, yung rehabilitation nasa 6 months to 1 year yon. Okay, so it requires a lot of money talaga. Okay, but this is more definitive, okay, than the angioplasty. Okay, all right. May question ba, okay, for acute coronary syndrome? May question po? Right, thumbs up. Guys, nandiyan pa ba? Okay, thank you very much. Okay, let's continue with the stroke, no? Okay, kasi medyo mabilis lang yung mga 10 minutes lang. Okay? Right? The essential, okay, for the stroke discussion, okay, is saan ba yun? The 8 Ds, no? Okay, of chain of survival, okay, of stroke. Okay? Yan. So these are the 8 Ds, okay, of chain of survival of stroke: detection, dispatch, delivery, door, data, decision, drug, and disposition. Okay, all right. Detection is the early detection, okay, of the early signs of stroke, no, using the recommended Cincinnati scale, okay, the 3 Ds, no, okay, initially, drift of the arm, drooping of the face, and dysarthria or slurring of speech, no, okay, any, okay, of this sign, okay, is a significant, no, okay, recognition, okay, of the early sign of stroke, okay, so the patient, okay, must be delivered to the hospital, so we have to call 911, and that is the dispatch, okay, all right. So from the dispatch, okay, there is a delivery, no, okay, of the patient, okay, to the definitive hospital, and it must be to the a hospital that has a stroke unit, preferably, okay, a tertiary hospital with a neuro, no, okay, ICU or stroke unit. All right, okay, now, okay, from the door, okay, to the physician, okay, there should be at least or within 10 minutes, okay, the physician, okay, must evaluate, okay, the patient, okay, with stroke. And within 15 minutes, okay, from door, okay, to the evaluation, okay, there must be a referral, okay, to neurologic expertise. Okay? Kasi di ba sa hospital, ROD, right? Sa ER, ROD. Kailangan within 15 minutes na i-refer na dapat ni ROD yon kay neuro. Alright? Ganun lang dapat kabilis. Okay? Door to CT scan, okay, we have the within 25 minutes. Okay? Which is not happening in the Philippines. Okay, dito, okay, 2 days na hindi pa CT scan. Okay? Alright? So ganito lang daw dapat kabilis. Within 25 minutes, kailangan the CT scan, okay, should be facilitated. Okay? And within 45 minutes, okay, there should be, okay, a result, okay, for the CT scan in order for us to give, okay, necessary intervention, and that is within 60 minutes. All right? Okay. For the hemorrhagic type, okay, of stroke, okay, within 2 hours, okay, the patient must be, okay, available, okay, for neurosurgery. All right? Or, okay, if the hospital is not capable of doing so, okay, the patient must be transferred to definitive hospital. Okay? And from door to admission, okay, for infarct type, okay, it should be within 3 hours only. Okay? All right? Okay, the PGH, okay, is now doing this principle. No? Okay, and according to their studies, okay, the response, no, okay, of the condition of the patient, okay, is very good, no, okay, in terms of the recovery. Okay, all right. If there is a hemiplegia, no, okay, the recovery phase is shorter, okay, than usual. All right. Ginagawa na nila ito, no, okay, sa PGH. Okay. All right. Question, okay, for the stroke. Question? None. Okay, the management, okay, for stroke is of course very technical, okay, but for the acute coronary, but the pharmacological therapy, okay, is the same with the acute coronary syndrome. Okay, we have the antiplatelet, okay, we have the anticoagulant and fibrinolytics, okay, in or for an infarct type. But for hemorrhagic type, of course, okay, we have to do the neurosurgery. All right. Okay, now let's have a 10-minute break. Okay, then we will discuss the last topic now in ACLS, okay, which is the airway management. Okay, so my time is 11:31. We will resume at 11:41. Okay, and right after that, okay, lunch break natin. Siguro mga 40 minutes na discussion yon or 30 minutes. Okay, all right. Let's have a break first. Lunch break. Okay? All right. This is supposedly chapter 2 na pero hindi ko pinagsunod-sunod. Okay? This is airway management. Okay? The outline, okay, includes, okay, the considerations, okay, for the status of the respiratory compromise. okay, the different devices that we use, okay, support, okay, for the airway and breathing, okay, and as well as, okay, for the advanced, no, okay, airway management. All right. Okay. Now, it is very important, okay, for us, okay, to know, okay, the circulatory compromise. Okay. All right. The respiratory distress, the failure, and respiratory arrest, no, can reflect increasing levels of severity of respiratory compromise. Okay. So these are the three, no, okay, status, okay, that we have to assess, okay, from the patient. All right. Okay. These are the signs of adequate ventilation, okay, the ability to breathe at a regular rate and within normal limits for the patient's age. An equal rise and fall of the chest with each breath, an adequate depth of breathing, okay, and ability to speak in full sentences, okay, without pausing, right? Okay, these are the signs, okay, of inadequate ventilation. A breathing rate that is too fast, okay, or slow, okay, for the patient's age. Abnormal breath sounds, okay, especially the audible sounds, okay, that we can heard, okay, without the stethoscope, okay, the wheezing, okay, the stridor, the crackles, yan, mga ganyan, no? Okay, abnormal work or effort of breathing, okay, irregular breathing pattern, anxious appearance, concentrating on the breathing, okay, sometimes hindi mo na siya makausap kasi the patient is trying, okay, to get a position of comfort, no? Confusion, restlessness, depth of breathing that is usually unusually deep, no, or shallow, inability to speak in complete sentences, inadequate chest wall movement, okay, sometimes naiiwan yung kabila, no? Okay, all right, but more on trauma, no? And pain with breathing, all right? Okay, these are the signs of respiratory distress with corresponding interventions. Okay, we have mental status change, okay, due to the decrease, no, okay, of the oxygenated blood, no, in the brain, okay, but the mental status change, okay, is just a mild, no, okay, change, okay. Nagkakaroon lang siya ng parang irritability, yan, no? Okay, all right, but the comprehension, okay, is still, okay, or the patient is still comprehensible, no? Nasal flaring, okay, pallor, okay, or mottling, as or due to the decreased perfusion, okay, retraction. The retractions can be seen, okay, supra sternally, no, okay, and sometimes and intercostals, no, okay, and in the sternal, no, area, okay, of the chest. Okay, stridor, no, okay, tachypnea, wheezing, the abdomen and the diaphragm. Okay, so in respiratory distress, we have to position the patient, or we have to position the patient, okay, according to his or her comfort. Okay, but we have to consider also, okay, the primarily, okay, the high Fowler's position. Okay, supplemental oxygen, okay, if the oxygen saturation is indicated only, okay, it means, okay, if the oxygen saturation is still normal, we don't need to give an oxygen therapy. Okay, and pharmacological therapy, okay, such as the bronchodilators, no, specifically, okay, if there is a wheezing, okay, that is caused by asthma attack, okay, or narrowing, okay, of the. All right, respiratory failure, okay, we have agitation, irritability, confusion, and lethargy, okay, due to the, of course, okay, prolongation, okay, of the decrease in oxygenated blood flow. Accessory muscle use, nasal flaring, pursed lip breathing. Pursed lip breathing is a compensatory action or mechanism of the body, okay, for respiratory failure or difficulty of breathing. Okay, when we do pursed lip breathing, okay, it can actually decrease, okay, the heart rate and the work of breathing. Okay, kumbaga parang nare-relax, no? Okay, when there is a pursed lip breathing. All right. retractions, okay, tachypnea, okay, pallor, mottling, and cyanosis. This time, okay, in respiratory failure, there is a process of cyanosis, okay, which is a severe, no, reduction or a severe reduction, okay, of the oxygenated blood flow, okay, in the cells, okay. All right, so nagkakaroon na tayo ng problem, okay, with our perfusion, okay. Tachycardia, bradycardia, okay. All right, guys, nagkakaroon tayo ng tachycardia or bradycardia or other tachydysrhythmias, okay, due, okay, to the alteration, okay, of the electrical conduction system or the normal process, okay, of the electrical conduction system in the heart, okay. Kasi, okay, nagkakaroon ng decrease, no, okay, supply of oxygen, okay, or oxygenated blood in the tissues, no, okay, surrounding the pacemakers, okay. All right, so the interventions, okay, we have the suctioning, of course, okay, if we have secretions, okay, supplemental oxygen, okay, non-invasive positive pressure ventilation using the bag mask ventilation, okay. All right. If the patient has a respiratory failure, okay, the oxygen mask, okay, may not be sufficient, okay, due to the very weak, no, okay, breathing pattern, okay, kaya kailangan niya ng positive pressure, okay, for the comfort as well of the patient, okay, to help to inhale, okay, the air, okay, or to give, no, okay, more concentration of oxygen. Okay, treatment of specific contributing or causative factors is also necessary. Okay, all right. So if the respiratory failure, okay, is not managed, okay, after a few minutes or after a few moments, respiratory arrest can happen. Okay, pag sinabi natin arrest, okay, there will be no spontaneous breathing. The patient may become unresponsive, okay, no visible chest rise, no ventilatory effort, and there will be a limp muscle tone. Okay. Manual airway maneuvers, okay, through the head to chin lift, okay, or the jaw thrust, okay, is very necessary. Foreign body removal, okay, if the cause of arrest is a foreign body. Oral or nasal airway insertion, okay, to help, okay, the maintenance, okay, of an open airway. Suctioning, bag mask ventilation. Advanced airway insertion is the primary concern, okay. Since wala na tayong spontaneous breathing, okay, we have to insert the advanced airway or endotracheal tube. Okay, all right. Okay, now we have two major assessment, okay, for the airway management. Okay, we have the assessment of the oxygen saturation and the carbon dioxide saturation. Okay, all right. The oxygen saturation is monitored, okay, and assessed through pulse oximetry. No? Okay, this is a device that measures, okay, the percentage, okay, of hemoglobin that is saturated with oxygen, okay, in pulsating capillary bed. So there is a probe, okay, or a small device, okay, that will be attached, no, okay, covering your finger, right, okay, to assess for the capillary bed saturation of oxygen. All right. Okay. So these are the possible indications, okay, for continuous pulse oximetry monitoring. A patient with critical or unstable airway. Okay. If there is a respiratory distress and respiratory failure, and of course during respiratory arrest or any, okay, of these three respiratory compromise status, okay, we need to assess, okay, for the continuous monitoring of the oxygen saturation. Okay. A patient who requires oxygen therapy. If the patient is already in oxygen therapy, we have to monitor continuously the oxygen, okay, whether, okay, to assess, okay, if the oxygen therapy, okay, is sufficient, okay, or not enough, okay. All right, during inter-hospital transfer, okay, for critically ill patient, during hemodialysis, okay, a patient who has a condition or who is undergoing a procedure that alters oxygen saturation, or a patient who has a condition or history that suggests a risk for significant desaturation. Okay, the continuous monitoring of oxygen, okay, is also, okay, necessary, okay, during the surgical operation. Okay, okay, but sometimes, okay, there is inaccuracy. Okay, and these are the factors that affect the accuracy of pulse oximetry reading. Okay, anemia, right? Okay, because of the problem, okay, with the hemoglobin, okay, in the RBC. Okay, artificial acrylic nails and dark metallic polish, no, okay, it can impede, okay, the the infrared light, okay, passing through the nails, no? So in ER pa lang, okay, kailangan tanggalin na natin yung any dark metallic nail polish, no? Okay, and acrylic nails. Okay, bright ambient light, specifically here in the Philippines, okay, we use the drop light, no? Okay, so you have to probe, okay, the device, no? Okay, on the opposite side, okay, of the drop light, okay, para hindi siya hindi ma-concentrate, no? Okay, yung light, no? Okay, doon sa device, no? All right. Dark skin pigmentation, okay, but this is a consideration for a Western country, no? Medication, okay, such as vasoconstrictors, okay, motion artifact, no? Motion artifact yun yung mga malilikot na pasyente, okay? Especially the toddlers and agitated adult, no? Okay, and poor peripheral perfusion as a result of cardiac arrest, shock, hypotension, or hypothermia. Okay, all right, guys. During the resuscitation or cardiac arrest, okay, or code blue, no, we do not measure or monitor the pulse oximetry, no? Kasi wala talaga tayong makukuha or mali, no, yung reading niya. Okay. All right. During shock, okay, the oxygen therapy is very necessary kasi we cannot able to identify, okay, the precise calculation of the oxygen saturation. Okay. All right. And during hypothermia as well. All right. So aside from the oxygen monitoring, okay, we also have the carbon dioxide monitoring. This is a continuous analysis and recording of CO2 concentrations in respiratory gases called capnography. All right. If in oxygen monitoring, we have pulse oximetry, okay, we have the capnography in carbon dioxide. It enables the early recognition of hypoventilation, okay, apnea, okay, and airway obstruction. All right. These are the examples of situations in which exhaled CO2 monitoring is commonly used. No? Assessment of adequacy of ventilation in patients with altered mental status, okay, bronchospasm, asthma, COPD, anaphylaxis, heart failure, drug overdose, stroke, shock, or circulatory compromise. Again, okay, to enable the medical practitioner to early recognize the hypoventilation, apnea, and airway obstruction. All right. So aside from this, okay, it can be used to confirm, okay, the correct tracheal tube placement and continuous monitoring of tracheal tube position. Okay, so there is a device, okay, that is placed in between the endotracheal tube and the connection, okay, to bag mask ventilation. This is called, okay, the colorimetric capnometer. Okay, all right. So this is connected, okay, to the endotracheal tube, and on the other part will be connected to the bag mask ventilation. Okay, in this area will appear, okay, the presence of CO2, no, okay, from the exhaled gas, okay, from the lungs, okay, to assess for the patency, okay, of the endotracheal tube. No, okay, if there is insignificant amount, okay, of CO2 gas, okay, that is being released, ibig sabihin baka barado, no, okay, yung initially baka barado yung tube natin. All right. This is a digital capnometer, okay, that can be used, okay, to monitor, okay, the carbon dioxide in a specific interval, okay, of monitoring. Okay. All right. Evaluation of the effectiveness of chest compressions during resuscitation efforts, okay, and the detection of the return of spontaneous circulation. Okay. Since we cannot able, okay, to assess, okay, for the oxygen saturation during the resuscitation, okay, we can able to assess for the carbon dioxide this time, okay, and when there is a continuous significant amount, okay, of the release of carbon dioxide during the resuscitation, there is a great chance, okay, for the survival of the patient. Okay, right? And this is used, okay, abroad, no? Dito lang sa Pilipinas hindi ginagawa ito. Okay? Ibig sabihin daw maganda or effective yung nagiging CPR natin when there is a significant amount, okay, of carbon dioxide, okay, that is being released. Okay? Kasi there is, no, okay, a proper exchange of oxygen, okay, and carbon dioxide. All right? Okay. Monitoring exhaled CO2 levels in patients with suspected increased ICP and procedural sedation and analgesia. Okay. The normal range of the carbon dioxide is, or the end-tidal carbon dioxide is between 33 and 43 millimeter mercury. Okay, all right. Don't be confused with the ABG. Now, the ABG has, or the carbon dioxide in ABG is 35 to 45, now, if I'm not mistaken. Okay, all right. Oxygen delivery devices are very important. Okay, this is how we choose the device that we can use for the different status of the patient. Okay, all right. If the patient is still in respiratory distress, with an oxygen saturation of 90 to 94%, we can use the nasal cannula. All right. Okay, we can use this nasal cannula up to 5 liters per minute. Okay, flow rate. Okay, that can give an oxygen concentration of 23 to 32%, right? Okay, advantages of nasal cannula. Okay, the patient may be comfortable, and well tolerated, kasi it does not interfere, with patient assessment or impede patient communication. Okay, it also allows, for talking and eating. Okay, kasi the source can only be in contact with the nares of the patient, no? Sa butas lang. All right? It doesn't cover the whole face, or the mouth and the nose of the patient. Nor the breathing of expired air can be used with mouth breathers and useful for patients who are predisposed for CO2 retention. Can be used for patients who require oxygen but who cannot tolerate a non-rebreather mask. No? Okay, any mask, any oxygen mask, can have a suffocating effect or feeling, that can be experienced by the patient, especially if the patient has a very or has intolerable difficulty of breathing. All right. Disadvantage can only be used in spontaneously breathing patient kasi this is not a positive pressure ventilation. Okay. So kapag walang spontaneous breathing, we cannot use this, no? As well as the mask. No? Easily displaced, nasal passages must be open, involves a drying of mucosa that may cause sinus pain. Okay. This is due to or to prevent the drying of mucosa, you need to monitor the level of the water in the bubbler. Kasi the water in the bubbler can humidify the oxygen. Right? Oxygen is dry, no? From the tank or from the source. All right, tubing may cause skin breakdown or irritation at the top of the earlobe. So you need to always check for the integrity of the skin. Deviated septum in mouth breathing may reduce FiO2. And if you increase the oxygen flow rate to 6 and above, it will not enhance the delivered oxygen hanggang 32%. To 32% lang siya, no? All right, okay. Simple face mask, no? Is used for respiratory distress, with oxygen saturation of below 90%. Okay, all right. So we can use these masks for up to that can give 35% to 60% of oxygen concentration. Okay, these are the parts of the mask. The mask itself, the oxygen inlet, connected to the direct source. The nose seal guide, the strap, and the exhalation ports. This port, is the passage of the exhaled air when the patient exhales. All right, and this is also the reason why the oxygen concentration is just 35% to 60%, because there is a dilution of air, or ambient air from the surrounding of the patient. All right. Advantage, of course, it has a higher oxygen concentration than the nasal cannula can give, right? Disadvantage, just like the nasal cannula, it can also be given, it can only be given to a patient with spontaneously breathing patient. Not well tolerated by severely dyspneic patient, kasi pag severely dyspneic ang patient, there is an intolerance of the space. Okay, especially naka-cover, okay, yung mouth and yung nose ng patient. Can be uncomfortable, difficult to hear when the patient is speaking, must be removed during meals, requires tight face seal, okay, to prevent the leakage of air. Okay, when there is a leakage of air, hindi natin na-monitor, okay, the 35 to 60% okay, will be reduced. Okay, all right? So there must be, no, okay, a fitted, okay, side against the face okay, of the patient. Okay, side holes in the mask permit inhalation of room air. Okay, and oxygen flow rates of more than 10 liters per minute do not enhance delivered oxygen concentration. So hanggang 10 lang siya. Okay, all right. Rebreather masks. Okay, the difference of the rebreather masks, okay, as a whole, okay, to the simple face mask is the presence, okay, of the reservoir. Okay, the reservoir, okay, has a direct, no, okay, contact, no, okay, with the source. Okay, so the oxygen here is 100%, okay, concentrated. Okay, then once the patient inhales, okay, it will inhale the oxygen here. However, due, okay, to the side holes, okay, there will be dilution of air, kaya nagiging 35 to 60%. Now, the same with the simple face mask. Now, the difference amount of non-rebreather mask to partial rebreather mask is the side holes, okay, has valves, no? Okay, this valve, okay, permits, okay, the sealing of the air from diluting the 100% oxygen. Okay, right? So when the patient inhales, okay, this will close, no? Okay, as the suction, okay, as the negative pressure, okay, pulls the valves towards, okay, the holes. Okay, all right. So the delivered oxygen concentration, okay, can be now higher than the partial rebreather mask, which is 60%, now, and to 80%. Okay, the rebreather mask, specifically the non-rebreather mask, okay, is indicated for respiratory failure. Okay, while the intubation is being prepared, no, okay, or waiting for someone, okay, to intubate the patient. Okay, right? Or, okay, if the simple face mask and partial rebreather mask, okay, cannot, no, support, okay, to increase the oxygen saturation of the body. Okay, all right, all right. The advantage and disadvantage is the same with simple face mask. Okay, manual air maneuvers, okay, were discussed, no, yesterday. Okay, ito lang yung head tilt, chin lift, and jaw thrust na diniscuss natin yesterday. So hindi na natin yung I discuss. All right, suctioning, okay, is very important as well kasi the secretions, no, if there is a difficulty of breathing, there is a tendency, okay, that there will be an accumulation, okay, of the secretions, no, inside. Okay, so in any compromise or respiratory compromise status, okay, we should have a standby suctioning, no, okay, materials, no, at bedside. Okay, all right. This is just a review. Okay, suctioning is performed for the following reasons: to remove vomitus, saliva, blood, and other material, okay, from the patient's airway, to maintain patency of an artificial airway. Example, if the patient has an endotracheal tube and tracheostomy tube, okay, to reach the bottom, to pass through to the lower airway and to obtain secretions for diagnosis. All right, we have two types of suction catheter. Okay, the first one is the rigid catheter. This is used, okay, for the upper airway or for the mouth, okay, with a larger circumference, okay, than the soft catheter. Okay, all right, to easily, no, okay, drain, okay, the secretion, okay, from the mouth. All right, the soft suction catheter, okay, is used for lower airway, no, okay, to reach the area, okay, or the oropharynx and nasopharynx, no, okay, when there is an endotracheal tube or tracheostomy tube. Okay, right? Here in the Philippines, we do not use the rigid catheter. Okay, in we use the soft catheter, no, even if the suctioning is for the upper, no, okay, airway or the mouth. Okay. Okay. Again, a suction catheter is inserted without applying suction. Suction is applied as the catheter is withdrawn and should not be applied more than 10 seconds to avoid hypoxia kasi it sucks oxygen also. Now, after suctioning, reevaluate airway patency and auscultate lung sounds, okay? To know, okay, if there is an additional suctioning, okay, or if there is a significant improvement. Okay, document the amount, color, and consistency of any secretion, specifically, okay, if there is a blood in your secretion. Okay, all right. Airway adjuncts, okay, are the materials that can help the maintenance of the open airway. Okay, all right. This is an oral airway. Okay, this is an example of an oral airway. Okay, it has a space inside, okay, for the that permits the air, okay, from accessing, okay, the lungs. No, okay. So when we insert this, okay, because of its contour, okay, it will support the back of the tank, okay, from not falling, okay, and causing the sizing is very important, no, okay, kasi when the size is too long, okay, we can push, okay, the epiglottis, okay, but and if the oral airway is very short, okay, it pushes the back of the tongue, okay, therefore it can block the airway as well. Okay, so to obtain a proper sizing, okay, the size of the oral airway, okay, must be, okay, equal, okay, or equivalent, okay, to the space between the lower part of the earlobe, okay, to the tip of the lips. Yeah, okay, right. So that is the proper sizing. Okay, all right. This is the nasal airway. Okay, it is the same. The use is the same, okay, with the oral airway. It's just that the nasal airway is inserted into the nares, okay, of the, or into the nose of the patient. Okay, all right. The same principle lang din. Okay, proper sizing again is important. Okay, the size, okay, must be equivalent to the space between the lower part of the earlobe, okay, to the tip of the nose, right? Okay, then we apply lubricating gel, okay, as we, before we insert, okay, the tube, kasi it is rubberized plastic, so it is somehow or a little bit painful, okay, due to the friction that it can create now against the membrane, okay, of the nose. All right, positive pressure ventilation is the ventilation using the bag mask, okay, all right. It means we have to push, okay, the air inside, okay, into the lungs, okay. That cannot be provided, okay, by the use of nasal cannula and face mask, okay. All right. NPPV is the delivery of the ventilator support a spontaneously breathing patient without using an invasive artificial airway. Okay, example, the endotracheal tube and the tracheostomy tube. Okay, all right. So this is the bag mask ventilation. Okay, so to use this, okay, actually it is recommended, okay, to use by the single rescuer only. Okay, I mean 2 or more, okay, rescuers. Okay, right? Kasi if you are just a single rescuer, okay, after you compress the chest, okay, for 30 compressions, okay, you have to position yourself, okay, to operate the machine, and that is very tiring. Okay, but when, okay, you are when you have a companion with you or you have a teammate, okay, you can operate the machine, no? Okay, alone, right, using the easy clamp technique. Okay, all right, so you position your hands na in easy position, okay, position, okay, of the 3 fingers, the middle finger, the ring finger, and the small finger, okay, and the C position of your thumb and index finger. Okay, the C position of your hand or your fingers, okay, must support the top of the mask, no, like this. Okay, and the E position, okay, must, okay, hook, no, okay, to the angle of the jaw, okay, to hyperextend, okay, the neck. All right. Okay, however, okay, it can also be used, okay, by 2, okay, providers. Okay, this is a thinner eminence method, and this is more recommended, okay, than the easy technique. Okay, all right. You use the jaw thrust technique, no? Okay, just like this, no? And the other provider, okay, will squeeze the bag, okay, for the ventilation. Okay, in this way, okay, there is a minimal chance of um, escape of air, okay, through the sides of the mask. Okay, kasi naka-sealed na siya, no? Okay, totally. All right. Okay, we have different sizes, okay, of the bag. It depends on the size of the patient. Okay, the big one, okay, is for adult, okay, and this is for the pedia, and this is for infant. Okay, all right. Make sure, okay, you have the different sizes, okay, of the bag. No, because we cannot use this for infant. No, otherwise there will be hyperventilation. Okay, and the amount, okay, of air here cannot be tolerated, okay, by the volume, okay, of the lungs of an infant. Okay, all right. So advantages: can provide means for delivery of an oxygenated enriched mixture to patient, okay, for 80% to 100%, now approximately. Okay, can be used with spontaneously breathing patient as well as for non-breathing patient. Okay. All right, conveys a sense of compliance of the patient's lungs to us to the bag mask device operator. Okay, when the when the provider squeezes the bag, okay, to ventilate, okay, there must be a chest rise. Okay, right. So the provider can assess, okay, that whether, okay, the ventilation is proper, okay, or not. All right. Provides a means for immediate ventilatory support. Okay. Disadvantage, of course, it requires practice. Okay. Delivery of inadequate tidal volumes, okay, based on the amount of the volume okay, of the air, okay, in different age group. Okay. It can cause fatigue, no? Okay, but it's very rare, no? And it can lead to possible gastric distension, okay, if we squeeze the bag frequently. Okay. All right. Again, okay. The the ventilation, okay, through the bag mask is very similar, okay, to the mouth to mouth resuscitation. Okay. If the patient has no spontaneous breathing, okay, we have to give uh we have to give 10 to 12, no? Okay. Ventilation per minute. Okay, that is 20 to 24, okay, ventilation per minute. Okay. Per 2 minutes pala. Right? Okay. If the bag mask is connected to the advanced airway, okay, the ventilation must be every 6 seconds only. Okay. All right. Now, speaking of advanced airway, okay, we have two types of advanced airway. We have the extraglottic, no, airway device and the intraglottic airway device. Extraglottic, no, airway devices, okay, are inserted blindly. Okay, we do not need to use laryngoscope. Okay, all right. It can be placed, okay, while cardiopulmonary resuscitation is in progress, thereby minimizing interruptions, okay, when performing chest compression. Okay, and sometimes, okay, it is, or most of the time, it is used by the EMS. Okay, while the ambulance, okay, is en route. No, okay, the insertion, okay, of a device, okay, blindly into the mouth of the patient, okay, will be inserted into the esophagus, okay, for 90% of chance. Okay, all right. So these are the examples of the extraglottic devices: esophageal tracheal combi tube. Okay, this is how it looks like, no? Okay, when inserted. Okay, it is intended actually, okay, to be inserted into the esophagus. Okay, all right. So there are two tubes, no? Okay, this tube is connected, okay, to this outlet. Okay, and this tube is connected to the outlet here. Okay, the holes here, okay, in between the inflatable cuff. Now, when you introduce air, okay, in this tube, okay, the air will pass, okay, through these holes, no, therefore, okay, the air will go to the lungs, or will be inserted, or will be inhaled, no, okay, into the lungs. Okay, all right. King laryngeal tube airway. Okay, this is how it look like, no? Okay, when inserted, no? Okay, again, it is intended to be inserted into the esophagus. So when you introduce air, okay, into this inlet, okay, the air will exit, no, here in the holes. Okay, the air will go to the lungs. Okay, kasi the esophagus is already blocked. Okay, laryngeal mask airway. Okay, this is how it looks like, okay, when inserted. Okay, it masks, no, okay, the esophagus, okay, and the surrounding spaces, okay, of the airway. Okay, so if you introduce air here, okay, it will the air will exit, no, into the hole, no, okay, at the middle of the mask. Okay, so therefore, okay, the air, okay, will go to the lungs. Okay, all right. Okay, so these are the extraglottic, no, okay, devices. The intraglottic device, okay, is simply, okay, the endotracheal tube. Okay, all right. So we have to use the laryngoscope, no, okay, when we use the endotracheal tube, kasi it is intended to be inserted only, okay, in the trachea. All right. Okay, so this is an example of laryngoscope. Okay, it is a combination, okay, of a barrel, no, and a blade. All right, the blade, the barrel has the battery, and the blade has the bulb. Okay, if we assemble the two, okay, it can produce a light, no? Okay, kasi madilim doon sa loob. All right, we have two types of blades, no? Okay, we have the Macintosh and we have the Miller. The Macintosh is the curved one, and the Miller is the straight one. Okay, the Macintosh is used, okay, for regular insertion. Okay, however, okay, for difficult insertion, okay, the Miller, okay, is used kasi mas payat siya, no? Okay, and mas mahaba. Okay, by the way, guys, okay, the indication for advanced airway management, okay, or insertion of the endotracheal tube, okay, is primarily, okay, during the respiratory failure, okay, and respiratory arrest. Okay, also, okay, tube must be inserted, okay, during the continuous narrowing of the airway, okay, specifically during the bronchial asthma and acute exacerbation, and the edema, okay, of the airway. Okay, right, kapag may anaphylactic shock. If there is an absence of gag reflex, kailangan din nating intubate yung patient, okay, to prevent the aspiration. Okay, if there is an airway trauma, okay, for example, okay, and ring bronchoscopy, okay, kailangan natin ng intubation. All right. In this time of pandemic, okay, respiratory distress pa lang kailangan ng intubate yung pasyente, okay? Especially, okay, if the oxygen saturation is not rising, okay? To minimize the use of bag mask ventilation, okay? To minimize the spread, okay, of the aerosol. All right. Excuse me. This is an example of endotracheal tube. It comes in different sizes from 2.5 to 10. What we use for adult is from 7 to 10. All right. And the rest, okay, for children and infants. Okay. All right. So these are the common parts, no? Okay. We have the adapter universal size. Okay. All right. So that any tubings, no, okay, may be fitted. All right. We have the body, okay, of the tube, no, it has level here, no, okay, the normal level, okay, for adult is 21 to 23. Okay, it also has the X-ray line, no, okay, at the side, okay, for post-intubation X-ray, okay, so that we can see, okay, the proper depth of compression, proper depth of insertion. All right, the balloon cuff, no, okay, the balloon cuff, okay, holds the tube in place, no, against the wall of the trachea. Okay, it also prevents the aspiration kasi naka-block na yung trachea, and it can also prevent, okay, the exit of Okay, we can have 1 hour lunch break. Okay. Okay, you can Zoom para hindi na kayo mag-on. Para hindi na kayo mag reconnect, no? Alright. The further instruction of the WePump main admin. Okay? All right. So thank you very much, guys, and I hope I imparted, no, okay, something, no, with regards to the principles of advanced cardiac life support, no, okay, for you to use, no, okay, in your practice. Okay. All right. And I hope you to stay safe. Okay, and good luck. No? Okay. Thank you very much. Okay. We pump. Okay. The floor is yours. Okay. Yes, thank you very much, Miss Christine and Miss Cyrene Argel. Thank you very much. You're welcome. Okay, thank you very much, everyone. Okay, let's have a lunch break, and please listen to whatever the further instruction of the We Pump main, okay, would be. Thank you very much. Okay, for this another segment, okay, of our virtual training. Okay, and this time, okay, we have the basic phlebotomy course. Okay, all right. Okay. Once again, okay, I am Roel Kulala. Okay, I am your instructor, okay, for today, okay, for this basic phlebotomy course. Okay. All right. Um, I just have a few disclosure, okay, for my presentation, okay, of the basic phlebotomy training. Okay. The content, okay, or the part of the content, okay, of this module, okay, was came from the World Health Organization. Okay, there is a section in their website, okay, for the standard practices, no, okay, in phlebotomy and injection, okay, considerations. Okay, so I asked the WHO, okay, for a permission, okay, to use, okay, the content, okay, of their segment, okay, and they approved me. Okay, so the content is legit. Okay, all right, and as well as, okay, from the Safe Injection Global Network sign. Okay, all right, there are also, okay, considerations, okay, from the Infusion Nurses Society. Okay, the new considerations, okay, for uh, the phlebotomy, no, and venipuncture. Okay, all right, again, okay, the our training is virtual, right? Okay, so let me compare lang, no? Okay, when the way we do, no, okay, during the face-to-face classroom time. Okay, this is 2 days, okay, supposedly, okay, for face-to-face classroom. Okay, the morning, okay, is the lecture, right, and the afternoon, okay, is the demonstration, okay, of the different skills, okay, for the return demonstration. Okay, and the return demonstration, okay, will be on the second day. However, okay, wala tayong face to face, no, okay, kaya puro lecture lang, no, hindi gagawin natin on this virtual training. Okay, so medyo yung time is also squeezed kasi wala rin tayong demonstration. Okay, so ipapakita ko lang sa inyo yung the principles. Okay, all right. Okay, so the objectives, okay, of our phlebotomy training, okay, is to improve knowledge and awareness, okay, of the risks associated with the phlebotomy among all health workers involved in the practice. Okay. All right. In the hospital, okay, the med techs, okay, the nurses and the doctors, okay, are the responsible, okay, for the phlebotomy, no, okay, and venipuncture. Okay. In other institution, okay, the respiratory therapist, okay, are responsible for the arterial blood gas, no? Okay, extraction. Okay, we have a segment here, okay, that I will discuss uh, all about the arterial extraction, okay, of this specimen. All right. Increase safe practices and reduce blood-borne virus exposure and transmission. So we have different considerations, okay, for the infection prevention and control. No, improve patient confidence and comfort, and improve the quality of the laboratory tests. Okay. All right. For a moment, guys. Target audience, key people who perform or supervise phlebotomy in the private and the public sectors in hospitals, community clinics, and other healthcare facilities, including those involved in home-based care. Okay, so before the pandemic, okay, we have participants, okay, from the hospitals. Okay, we have in-house, okay, training, okay, from the hospitals, okay, from the schools, okay, of medtech and nursing, okay, also for the standalone clinics, okay, and mixed participants, right? Okay, health trainers and educators, procurement officials, okay, or especially those who need, okay, to be aware of which equipment and supplies are safe and cost effective, kasi meron din tayong portion here, okay, that I will present to you the different engineering innovations, okay, of the syringes, okay, to prevent the needle stick injury. Okay, all right. Okay, the phlebotomy, okay, according, okay, to the definition, okay, long time ago, okay, from the root word, okay, of the word phlebotomy, okay, is the vein, okay. The phlebos, no, is equivalent to the vein, and the tome, okay, or tomi, okay, is the incision, okay. So before, all right, they do incision, okay, along the skin, okay, of the patient, okay, with a large vein, okay. So then then they bleed, okay, the patient with significant amount of blood, okay, all right, for different purposes, all right. Okay, so later on, discuss natin yan. Okay, all right. But now, according to Merriam-Webster Dictionary, okay, the definition, okay, of the phlebotomy is the letting of blood for transfusion. Okay, what we do, no, during the collection of blood specimen for the cross-matching and necessary, okay, for the blood transfusion, diagnosis or experiment, okay, for the laboratory test, and especially for treatment of disease. Now, specifically the polycythemia vera, okay, where we bleed 500 cc of blood, okay, from the patient, okay, to reduce the signs symptoms, okay, of the disease, okay, or illness. Okay, all right. Now, okay, from the history, okay, of the phlebotomy, okay, before, okay, they do, okay, the bleeding, okay, of the patient, okay, to cast off, no, bad spirits, no, and illnesses, okay, through lancet tool. They believe that if the person is ill, okay, there is a bad spirit inside. Okay, so in order for the bad spirit to be casted off, okay, they bleed, okay, the patient. Okay, but sometimes, but most of the time, the patient will dies, no? Kaya ang nangyayari, okay, tinigi, okay, to 1163, okay, the role, okay, of the phlebotomy, okay, was vested, okay, to the barber surgeon. Okay, kaya meron silang labaha, no? Kaya yung mga barbers merong labaha. All right? Okay, but that was before, no? Until the present day, okay, the bleeding, okay, and the blood extraction or phlebotomy, okay, are done, no? Okay, in the laboratory, okay, or okay, in the hospital. Okay? All right. These are the supposedly these are the skills, okay, that you have to perform, no, if we have a face-to-face classroom time. Okay, Venous extraction through the use of the syringe. Okay, venous extraction through the use of the butterfly. Okay, venous extraction through the use of evacuation technique. So tatlo yon, tatlong tusok, no? Okay, and another is the bleeding technique. Okay, all right. Just like what you experience, no, when you donate, no, okay, a blood, no. Okay, another extraction, okay, is the arterial extraction. Okay, so all in all, okay, you have 5, no, okay, skills, okay, to perform supposedly. All right. Okay. For capillary collection and peripheral smear, okay, we just do this, okay, for colleges, no. Okay, with medtechs, no. All right. Okay, so these are the best practices, okay, in phlebotomy according to the World Health Organization. Okay, planning ahead, using an appropriate location, quality control, standards for quality care for patients and healthcare workers, including the availability of the appropriate supplies and protective equipment, okay, availability of post-exposure prophylaxis, avoidance of the contaminated phlebotomy equipment, appropriate training in phlebotomy, cooperation on the part of the patients, and quality. How are we going to provide a quality, no, okay, laboratory samples? All right. Okay. So let's start, okay, with planning ahead. Okay. All right. Planning ahead is the most important part, okay, of carrying out any procedure and is usually done at the start of a phlebotomy session. Okay. What are the things, okay, to be planned? Okay. First case, of course, you must know the patient. Okay. All right. The case of the patient, okay, is very important. Okay. If there is a contagious disease, okay, or if you need to use different PPEs, no, okay, before extracting blood. All right. Okay, and using the appropriate location. Okay, there are two, okay, locations, okay, for the blood extraction and phlebotomy. Okay, the laboratory. Okay, the laboratory, okay, has an area, okay, where there is where there are materials, okay, to be used, okay, for the extraction. Okay, and the patient's room. Okay, the phlebotomist, okay, can extract blood, no, okay, in the patient's room. All right. Okay, the room, okay, and the area, okay, must be well lit, no, right? Of course, okay, we need to be precise, okay, when extracting the blood, right? Okay, so if ever, okay, we have an extraction, okay, in stat, no, okay, in during we time, okay, or madaling araw, okay, we have to consider lighting, no, okay, the entire room, no, even if the patient, okay, says natutulog siya, kailangan niya ng madilim, no, hindi pwede yun. Okay, all right. Or okay, there are others, okay, that are bringing, no, okay, a lighting material, okay, just to be precise, okay, with their extraction. Okay, all right. Quality care, okay, for patients and health workers. Okay, the number one is the availability of the appropriate supplies and protective equipment. Okay, provide hand hygiene materials. Okay, an alcohol rub, no, an alcohol, okay, is the number one, okay, material, okay, for the or as a protective, no, okay, means. Okay, well-fitting non-sterile gloves. Okay, this is very necessary. Okay, yes, we need to. Yes, we need to always wear gloves, no, okay, in any procedures, no, okay, but of course specifically, okay, for blood extraction, because we are dealing with the possible blood exposure. Okay, single-use disposable needles, syringes, or lancing devices in sufficient numbers, case to ensure that each patient has a sterile needle and syringe for or equivalent for each blood sampling. Okay. All right, make available sufficient laboratory sample tubes, okay, to prevent dangerous practices. All right, availability of post-exposure prophylaxis. Okay, this is a support service, no, okay, from the part of the employer. Okay, it should be promoted, okay, for those who undergo accidental exposure. Okay, PEP can help to avert no, HIV and hepatitis B infection. Avoidance of contaminated phlebotomy equipment. To avoid contamination, any common use items, okay, should be visibly clean before use on a patient, and a single-use item should not be reused. Okay, technically speaking, okay, all materials that should be used, no, okay, in a phlebotomy, okay, must be single use only. Okay, even the tourniquet, okay, must be single use only. All right. Okay, ang hindi lang single use, okay, is the tray, okay, or the phlebotomy tackle box. All right. Okay, training in phlebotomy. Okay, groups of health workers, okay, who historically, okay, are not formally trained in phlebotomy should be encouraged to take up such training. Okay, for example, nurses, okay, are not used, okay, to do blood extraction. Okay, they just acquire, okay, the skills, okay, of the phlebotomy, okay, or blood extraction, okay, during practice, no, okay, or because of the exposure, okay, in different cases. All right. Lax infection prevention and control practices result in poor safety, okay, for staff, no, okay, and risk to patients. The length and depth of training will depend on the local condition. However, the training should at least, okay, cover the essentials. Okay, here in the Philippines, okay, the Philippine Women's University, okay, before, okay, was offering the phlebotomy course, okay, and that is, I guess, 2 months, no, kasi with duty, no, okay, with hours, okay, of on the job training, okay. But I don't know, okay, today, okay, or before pandemic kung na-push pa nila yon, okay. All right, so the available training here in the Philippines, okay, is just like what we do, okay, a 2-day training or a 3-day training, right? Okay, in other countries, no, okay, if even if you are even if you did not take any healthcare course, no, okay, you can undergo, no, okay, a phlebotomy certification, okay, and that is I think 1 year to 2 years, okay, for you to work, no, okay, in the hospital as a phlebotomist, no, kasi alam naman natin, no, okay, in other countries, okay, they are following, okay, the job description, okay, kung ano ang meron sa job description mo. Okay, for example, no, nurse ka lang, okay? Nurse ka lang, no? Okay, hindi ka pwedeng hindi ikaw yung magtutulak ng pasyente, hindi ikaw yung maglilinis ng kung ano-ano, yan, ganyan. Okay? All right? Your specific role, okay, is to perform as a nurse, no? Okay, dito kasi sa Philippines, no, kapag nurse ka, lahat, no? Okay? Inaasa sa iyo, lahat pinapagawa sa iyo. All right? Okay. Alright, kaya walang gaanong certification dito, no? Okay? Kasi kapag nurse ka, you're expected, okay, to do more, okay, than your job description. Okay? Correct me if I'm wrong, pero that is the culture here in the Philippines. Okay? All right. Supervision of experienced staff and structured training is necessary for all the health workers, including physicians who undertake blood sampling. Okay, other institutions, okay, give free training, okay, for their staff, no, okay, that is the in-house, no, okay, training, or they invite, okay, different third-party organization or training center, okay, to conduct the training, right? Okay, patient cooperation. Okay, one of the essential markers of quality of care in phlebotomy is the involvement and cooperation of the patient. This is this is mutually beneficial to both the health worker and the patient. So, ibig sabihin, okay, you have to cooperate, okay, with the patient before, okay, and after your before and after the procedure. Okay, before the procedure, you have to explain, okay, the or what you have to do, okay, and what the patient may be experiencing, okay, and of course the purpose, okay, of the procedure. Okay, all right, that is one of the ways, okay, to establish the rapport, okay, with the patient. Okay, it is very significant, okay, for you to gain trust, okay, from the patient, kasi there will always be a complaint, okay, kapag hindi masyadong maganda, no, kaya yung naging process ng procedure. Okay, so there should be clear information, either written or verbal, and should be available to each patient who undergoes phlebotomy. Okay, all right. The factors that influence the outcome of the laboratory results during collection and transportation include knowledge of the stuff involved in blood collection. Okay, how are we going to extract the blood? What are the considerations, okay, for the uh, the extraction of the blood? Okay, the consideration, okay, for the transport. Okay, and the way of the needle, okay, to prevent hemorrhage abnormal. Okay, we have also the topic for that. The anatomical insertion site, okay, of for venipuncture. Okay, why you should not use, okay, the metacarpal vein, okay, over the antecubital vein. Okay, the use of recommended laboratory collection tubes, the different colors, okay, that corresponds to different laboratory test. Okay, the use of or the patient sample matching, okay, the correct principle, the principle, okay, of labeling, transportation condition, and interpretation of the result, okay, for clinical management. All right. Okay. So patient identification, okay, is a critical aspect of total quality care. Okay, it is mandatory that the phlebotomist who collects the blood specimen from the patient correctly identify the patient regardless of the clinical setting. Okay, right? Any mishap, okay, or incorrect information, okay, from the uh, information provided, and okay, and from the specimen label, okay, can result, okay, to a legal matter, right? So patients must be positively identified at the time the sample is drawn, and sample must be labeled on at the bedside or other collection site in the presence of the patient. Okay, that is the general rule. Okay, all right. So there are components, okay, that we have to consider, okay, in order for us, okay, to identify the patient. Okay, all right. But first, okay, um, we should consider, okay, the status of the patient, okay, whether the patient is stable, okay, or unstable, okay, or the patient cannot understand you, okay, or the patient is very young. Okay, all right. Okay, there are three components of patient identification: the patient himself or herself, okay, the wristband, and the request. Okay, all right. So the first thing to do, okay, is to ask the patient his or her name. Okay, you must not provide the name, okay, and wait for the yes or no answer. Okay, the name, okay, must be coming from, okay, the patient himself or herself. Okay, all right. Check the patient's wristband, okay, for verification. Okay, if the patient is able to give full name and the wristband agrees, okay, with the patient's statement, check the requisition and or reprinted label to be sure all information agrees. These include the hospital number, medical number, okay, I mean record number, okay, room number, correct spelling of the first, the last, and the middle initial, this the gender or the sex, and the date of birth. Okay, wait lang guys. All right. Okay, if there is a discrepancy, no, okay, between the information on the requisition or reprinted label and wristband, okay, do not perform the venipuncture, okay, until the situation has been resolved. Okay, so you have to call, okay, or aware the nurse, okay, that is familiar, okay, with the patient to provide positive identification and check to be sure the patient has a correct wristband. Okay, if changes are necessary, okay, the phlebotomist should notify appropriate personnel to make these changes. Let's say, for example, okay, um, the station, okay, is having a hard time, okay, providing the correct identification, okay, you can go back, okay, if you have something to do, okay, but make sure there should be a coordination, okay, between you, okay, and the station. Okay, all right. If the patient, okay, is unconscious or too young, okay, or mentally incompetent, or does not speak the language of the phlebotomist, okay, you must take this consideration. Okay, if the patient is unable to state his or her name, the wristband, okay, must be relied upon totally for information, and or a nurse familiar with the patient must be consulted to verify identification, okay, of the patient. Have the identifying person initial the tube. If this is not possible, phlebotomy should get name of person and document that as part of a computer workload entry, okay, or documentation. A friend or relative may identify a patient, okay, verify full name and the birth date, okay, but be sure all information agrees with the information on the request form or reprinted computer label, okay. If the relative, okay, or a person, okay, beside the patient, okay, do not know, okay, the information, okay, of the patient, okay, you have to rely on the healthcare provider, okay. All right, if the patient can be possibly identified, okay, perform the venipuncture and label, okay, the tube according to the protocol or the established criteria. Specimens must be labeled at the time of the collection in the presence of the patient. Okay, tube should be initialed by the phlebotomist to provide a mechanism, okay, for identifying the person who drew the blood. All right. If the patient can state full name or can be identified by a nurse, friend, or relative but has no wristband, notify the nursing station or patient nurse and request that the wristband be removed and the patient be identified according to the Once the band is in place, perform the venipuncture and label the tubes according to the protocol. Okay, you should have specimen. Okay, initials, okay, of personnel, okay, or personnel. Location of the patient, okay, whether the patient is in a critical area, okay, or in outpatient or special area or in regular room, no? Kasi it has something to do with the release, okay, of the laboratory test, okay. Source of specimen, okay, this is more specifically, okay, for the blood collection for culture and sensitivity, right? Okay, so if there is any error in collection, okay, do not do anything, okay, that can um, uh, do not do anything that can make the incorrect information not visible, okay, to legal implication. Okay.
What's the definition of illegal?
All right. Now just draw a single line, okay, through the incorrect information and replace the correct information, okay, with date and the initial, okay, of the personnel or the person, okay, that who corrected the changes, okay, parang sa nursing error correction na. All right. Okay. Now for the safety, okay, we consider the blood-borne pathogens, okay, infectious microorganisms which live in the bloodstream, okay. Of course, we can be exposed to the blood-borne pathogens, okay, if we are injured, okay, with contaminated needle, okay, and that is the needle stick injury, okay, or the needle prick injury, okay. All right. Not also, we can acquire, okay, different contagious diseases, okay, not only through the needle prick, okay, but also, okay, through the splash, okay, through our membranes, no, okay, or open wounds, okay. All right, you can also be exposed, no, if your mucous membranes, no, okay, including eyes, mouth, okay, or the inside of your nose come into contact with the contaminated body fluids, okay. So it is very important for us to plan ahead, okay, to know the case of the patient so that we can plan, okay, for the PPE, okay, to be used. All right. The Occupational Safety and Health Administration, mali ako dito, no? The Occupational Safety and Health Administration of the federal government has mandated the blood-borne pathogen training for all workers who are at risk for exposure. Okay? All right. The principle of emphasizing the blood-borne pathogen exposure is very necessary. No? Okay, so na-adapt na natin yan here in the Philippines. Okay? All procedures have infection prevention and control topic. Okay? All right. According to the OSHA, okay, the inclusion, okay, of awareness, okay, of the participants, okay, for the bloodborne pathogens, okay, must include standard precautions, the use of personal protective equipment, okay, hand washing, hazardous waste disposal, and the consideration for the needle stick and prevention act. Okay, all right. Is the is to treat no fluids as if they are infectious. Okay, potentially infectious body fluids include the blood, the semen, the vaginal secretion, the peritoneal, pericardial, and pleural fluids, and the saliva. Okay, sweat and tears are not generally considered infectious. Okay, but we wouldn't know. Okay, if that if the fluid is coming, okay, from or is a sweat, no, okay, or coming from the eyes. Okay, kaya in standard precaution, okay, all wet, no, okay, all wet something, okay, coming from the patient must be considered infectious. Okay, all right. The personal protective equipment must be considered also. Okay, and these are the basic, no, okay, even in pre-pandemic. Okay, we have the lab coat, we have the gloves, and we have the face mask. Okay, all right. Pero ngayon, okay, meron pa tayong mga bunny suit. All right. Okay, so it depende sa protocol ng hospital nyo, but these are the standards. Okay, the lab coat, the gloves, and the face mask. Okay, all right. Hand washing is also promoted. Okay, even if we are very tired of listening, okay, for the principle of hand washing. Okay, again, hand washing is the single most important infection control measure. Okay, wash hands thoroughly, okay, before, after, and between all patient contacts. So you have to take note of this principle. Okay, wash hands thoroughly before, after, and between all patients contact. Okay, be sure, okay, to turn off faucets using a paper towel, okay, to avoid contamination. Okay, after your hand washing, of course, okay, if you use your hands to turn off the faucet, okay, it will be contaminated by, okay, the handle, okay, of the faucet. All right, so during hand washing, okay, you have to remove your rings, no? Stand by the sink but do not touch it. Okay, kahit na flowing yung water, okay lang yon. Apply soap and rub hands together. Okay, both sides of the hand, between fingers, around the knuckles, and under the fingernails. Rinse the hands in a downward motion. Okay, dry hands with a clean paper towel. Okay, clean paper towel is now the recommended means, okay, to dry, okay, our hands. Okay, before kasi ang ginagamit ng mga hospital, okay, is the cloth towel. Okay, of course, okay, it is used, okay, by multiple na personnel. Okay, kaya it is already contaminated. Plus the fact na it is exposed. Okay, all right, turn off, okay, the water with another paper towel. Okay, the consideration, okay, of the hazardous waste disposal, and the number one, okay, is the sharps. Okay, so we have to use the sharps container, no, every time. All right, I mean, you have to have at least, okay, a small sharps container in your tackle box, no, okay, every time you do blood extraction, para right after your extraction, okay, you can easily discard, okay, the sharp, no, okay, in the sharps container. Okay, all right, the needle stick, okay, must be prevented, okay, by the programs, okay, of the infection control committee of the hospital, okay, regarding the infection or the needle stick injury prevention. All right, okay. Safety devices should always be encouraged. Okay, and there must be a program, okay, for the needle stick. Okay, and that is the responsibility, okay, of the infection control, okay, committee. Okay, so these are the do's and don'ts, okay, of the infection prevention and control practices, okay, in phlebotomy. Okay, do carry out hand hygiene. Do use one pair of non-sterile gloves, okay, per procedure or patient and or patient. Do use a single-use device for blood sampling and drawing. Okay. Do disinfect the skin and add the venipuncture. Discard the used device immediately into a robust, sharp container where recapping of a needle is unavoidable. Okay. Do use one-hand scoop technique. Okay, one-hand scoop technique is you hold the barrel, okay, with the needle, okay, with your hand, okay, and you scoop the cup, no, okay, without touching it. Okay. All right, that is a one-hand scoop technique. Actually, the one-hand scoop technique is not recommended, no, okay, if no, okay, there is an available sharps container, okay, near, okay, the personnel. Okay, do seal the sharps container with a tamper-proof lid, okay, to prevent, okay, the accidental leakage. Okay, all right. Do immediately report any incident or accident linked to a needle or sharp injury and seek assistance. Okay, start prophylaxis as soon as possible following the protocols. All right. Do not forget to clean your hands. Okay. Do not use the same pair of gloves, okay, for more than one patient. Do not wash gloves for reuse. No? Nung araw daw kasi nire-reuse ang gloves. Okay. Pero ngayon, wala na pong nire-reuse na gloves. Okay. All right. So, as an infection prevention and control nurse, okay, I'm very specific, no, okay, with the mode of transfer, okay, of the infection. Okay, so yung mga fast food, no, na merong kalokohan na na plastic gloves, no, all the time, okay, they prevent the I mean wearing gloves, no, okay, in specifically outside the hospital, okay, can prevent you, okay, from cleansing your hand, okay, by alcohol. Okay? Kasi ang thinking mo, may gloves ka na. So hindi ka na mag-alcohol. Kaya lang, yung hinawak mo, okay, sa isang bagay, may ahawak mo ulit yon sa ibang bagay. E paano kung merong infection doon sa nahawakan mo? Okay? Alright? So that mga kalokohan niya. Ay mga kalokohan dito sa Pilipinas yan. Yung gloves na outside the hospital, okay? Yung PPE ng mga non-healthcare providers, okay? Yung face shield, no? Okay? Well, that's my opinion, no? Okay, as an infection prevention control nurse. Kasi when you wear face shield, okay, are you sure, okay, you cleanse the face shield every now and then, or you use that face shield for a single use only? Okay, hindi naman, di ba? Yan ang ginagawa mo, no? Okay, tinutupi mo yon, tapos nilalagay mo kung saan-saan. Okay? Pero yung outside, no, okay, part, okay, or area, okay, hindi naman naki-cleanse. Okay, so that is the start of the transfer of the disease. Okay, all right. And what is the difference, okay, of that front side, okay, of the face shield being exposed, okay, to your body being exposed, no? Right? Kung ayaw mo may expose, huwag kang lumabas. Right? Okay, mga kalokohan. Anyway. All right, even in the hospital, no? Okay, I'm not telling you na to not to wear, okay, any PPE, no, in the hospital. Pero ako in the hospital, I do not wear, no, okay, a PPE. Okay, it's not that it's not that na matigas ang ulo ko, no? Hindi naman. Okay, kaya lang pag nag-wear ako ng bunny suit, no, sa hospital, okay? Am I sure, okay, na I can remove that without touching the outer part? Okay? Or else, kailangan maligo ako right after kung hubarin, no? Right? Kaya yung ibang hospital, no, wala nang nagsusuot, no. May mga hospital, especially in Manila, hindi na sila nagsusuot ng bunny suit, no, ng PPE. Okay? Kasi bukod sa it is very uncomfortable, okay, for the healthcare professional, the transfer of disease is or there is a risk, no, a great chance, okay, to transfer the disease. Okay, wearing of bunny suit, okay, is for isolation only, okay, not for regular ward or not for any personnel inside the hospital that is not who are not catering this patient with the infectious disease. Anyway. Do not use a syringe, needle, or lancet for more than one patient. Do not touch the puncture site after disinfecting it. And do not leave an unprotected needle lying outside the sharps container. Do not recap needle using both hands. No, okay. There's a possibility that maduling ka, no, okay, and the needle, okay, will not be directly, okay, the cap, no, okay, or sealed with the cap. Okay, do not overfill or decant a sharp container. Okay, and do not delay prophylaxis after exposure to potentially contaminated material beyond 72 hours. Okay, the PEP or the post-exposure prophylaxis may not become effective. Okay, all right. Okay, anatomy, okay, or the site location, okay, for our venipuncture. Okay, these are the major, okay, or the primary choice or blood extraction. The cephalic, okay, the median, and the basilic. Okay, all right. These are vein. Okay, para hindi ka magkamali, no? Okay, all right. Because as much as possible, okay, we do not do trial and error. Okay, all right. Okay, so now, okay, to locate the vein, okay, position the arm and apply the tourniquet. Okay, the tourniquet helps the distension of the vein. Okay, all right. If the source, okay, is cephalic, okay, or antecubital downward, okay, the application of the tourniquet must be 2 to 3 inches above, okay, the antecubital area. Okay, all right. Use the tip of your finger, okay, on your non-dominant hand to palpate the vein. Okay, the tip, no, okay, it must be the tip. Okay, it helps you determine the size, okay, depth, and the direction of the vein. Okay, all right. You must take, okay, consideration, okay, to the size, the depth, and the direction of the vein, because this is how, okay, you, or this is this will be your parameters, okay, when choosing the right size, okay, of the needle. Develop your sense of touch. Okay, the veins have bounds, okay, or resilient, okay, and the artery pulsate. Okay, actually we cannot in most of the population, okay, the artery, no, okay, cannot be palpated, no, okay, kasi malalim yun. Okay, so we just we can just assess, okay, the pulsation, okay, of the arteries. Okay, choose a vein that is large and well anchored. Okay, once you have chosen a vein, mentally visualize the location and the direction of the vein. Kasi once you cleanse, okay, the site, okay, you should not touch it anymore. Okay, all right, you can touch, okay, the area, okay, but it must be above, okay, the injection or the venipuncture site. All right, site to avoid: sclerose and thrombose veins, okay, feel hard and cord-like and lack resiliency. Okay, so we have to avoid the sclerose and thrombose vein. Okay, these veins are hard to penetrate. Okay, when there is a sclerose vein or thrombose vein, okay, there is a very thick, no, wall, okay, due to the plaque deposit, okay, and due to the arteriosclerosis. All right, so the tendency is, okay, if you puncture, okay, the vein, okay, with sclerosis and thrombosis, okay, the circumference is narrow, okay, because a narrow circumference of the blood vessel can contribute to the collapse, okay, of the vein. Okay, and of course, okay, if the tip of the vein, okay, is just lying, no, okay, within the thickness, okay, of the blood vessel wall, wala kang ma-extract ng blood. Okay, sites, okay, with extensive scarring, okay, should be avoided as well, and edematous area. However, if you do not have a choice, okay, we can also use, no, an edematous area. Okay, hematoma, okay, a part of the venipuncture site that has a hematoma. Okay, hematoma indicates blood leakage into the tissue. All right. Okay. Yeah. It can usually be experienced by the phlebotomist. No. Okay. Into the previous site, okay, of venipuncture. Okay. It can be caused, okay, by poor venipuncture technique, okay, bending the arm after the venipuncture, decreased platelets, okay, bleeding disorder, okay, and a very fragile veins. The site of mastectomy must also be avoided, okay, due to the lymphostasis that occurs on the side of the mastectomy and results in poor drainage of fluid, okay, and it may result, okay, in a painful venipuncture. All right, okay. Intravenous line site, okay, do not draw above the IV site, no, okay. The blood will be diluted with IV fluid, okay. All right, but if you don't have a choice, okay, we can also extract blood, okay, from that side, provided, okay, that we turn off the IV line, okay, for 20 minutes, okay, and we flush, no, okay, at least 10 to 20 cc of D5 water, okay, para walang halo sa kanya na IV fluid content. No, always remember that the IV fluid contains different electrolytes. Okay, so there will be an alteration or aberrancy, no, okay, in the result of the test. All right, indwelling lines. Okay, types include Hickman catheters and heparin locks. No, okay, use to administer medication and fluids, okay, but not for extraction. Okay, nurse, okay, may draw blood, okay, from these lines, okay, especially the phlebotomy, hemodialysis nurses, okay, or the cardiovascular nurses, no? Okay, pwede yon. Okay, pero for phlebotomies, hindi tayo pwedeng mag-extract ng blood. Okay, all right. Okay, equipment. No? Okay, what are the necessary equipment, okay, needed, okay, for the blood collection? Okay, of course, okay, we have the phlebotomy tray. Okay, this is an ideal, no, kay setup kay of phlebotomy tray, no? Yan, meron tayong mga gamit, no? Plus meron tayong kay a small sharps container. Yan, okay? And it must be cleansed, no? Okay? Every shift, right? Okay? It should be sanitized, no? Right? And kept organized and well stocked, no? Okay, if in this area, okay, ang nakalagay lang ay collection tubes, okay, wala dapat mahalong ibang collection tubes, okay, or syringes or other materials, okay. It must be kept organized para hindi magkamali yung phlebotomies, okay, during the blood extraction. All right? Okay, now, okay, we have the blood collection tubes, okay. It is a glass, no, or plastic tube, okay, with a rubber stopper, okay. Ito yung takip niya is a rubber stopper, right? It has a vacuum inside so that blood flow, okay, the blood will flow, okay, into the tube, no, okay, when we use the vacuum type, okay. All right, and sometimes, okay, there are, okay, collection tube, okay, that have chemicals, okay, for the different laboratory tests, okay. All right, this is the rubber stopper, okay, of the collection tube, okay. All right, this one, okay, is the plastic cup, okay. So pag tinanggal mo ito, okay, ang matitira ay ito, no? Okay, yung rubber stopper niya. Okay, but there are tubes na when you remove the plastic, na sasama na yung rubber tubing, okay, or rubber stopper niya. Okay, all right. Each type of stopper indicates different additive or a different tube type. Okay, and we also have sizes. Okay, for adult, okay, for pediatric, and this is for finger stick or heel stick. Okay, all right. And of course, sometimes it depends on the machine. Okay, kasi machine na kailangan ang collection tube is small lang, no, nasa 3 cc lang. May iba naman nasa 5 cc or even more, right? Okay, blood collection na okay, may be lost, no, okay, when you open. Okay, all right. So now let's discuss, okay, the different colors and additives of the collection tubes. Okay, lavender, okay, has an EDTA, okay, to prevent the clotting. Okay, this is for hematology studies, okay, for CBC platelet, okay, and for smearing. Okay, it should be completely filled. All right, it depends on the level, okay, indicated level, okay, on the collection tube that you are using. Okay, merong indicated level doon, no? For example, 3 2 cc, no? Okay, collection tube, may iba 3 cc, may iba 5 cc. Okay? All right? And it should be inverted after filling, okay? When we are talking about inverting, okay, the collection tube, okay, it is the way we mix the blood, no? Okay, hindi natin pwedeng i-mix yung blood ng sobrang parang ginagawa natin sa milk tea, no? Hindi pwede, no? Kasi it can hemolyze, okay, the blood. Okay? All right? So what we do to mix the blood is by inversion. Okay? So figure of 8 lang or kaya naman upside down inversion. Okay? Yun lang ginagawa natin. Okay? All right, light blue, okay, with sodium citrate, okay, for coagulation and clotting studies, okay, for partial thromboplastin, okay, and for prothrombin time, okay, and clotting time, okay, and again, it has an indicated level, okay, and must be inverted then, okay, after filling. All right. Green, okay, is with sodium or lithium heparin, okay, for testing requiring whole blood, okay, or plasma such as ammonia. It can also be used, okay, for some machines, okay, for the troponins, no, okay, or cardiac biomarkers. Red, okay, has no additives, no, okay, so the specimen, okay, that we will collect using the red top, okay, is intended to be to clot, no? All right, because it's a right? For the blood bank test, toxicology, and serology must not be inverted. All right, gray, okay, is rare. It can really laboratory. Okay, with inhibitor for glycolysis, okay, for glucose levels. Okay, the yellow, okay, has acid citrate dextrose, okay, for DNA studies, paternity testing, for serology, and also for chemistry. All right, royal blue, okay, is also rare. Okay, heparin is it has heparin, okay, or sodium anticoagulants. Okay. Designed, okay, to contain no contaminating metals, okay, for the trace element. And okay, when you have this, okay, make sure you use betadine, okay, aside from the alcohol, okay, to asepticize, okay, the site, okay, kasi this must be sterile. All right. Okay, expiration date of the collection tube must also be considered, kasi when the tube is expired, okay, the additives inside is already expired, and sometimes okay, the vacuum, okay, is already or has already escaped, okay, the collection tube. Okay, all right. Okay, so these are the blood collection method, okay, that we can use. Vacuum extraction system. Okay, it is a closed system in which the patient's blood goes directly from the vein into the stopper tube without being exposed to air. Okay, so ito yun, no? Extraction and then here, okay, for the vacuum to suck the blood, okay, that is the vacuum extraction. Okay, the needle syringe system, okay, is just the use of the needle, okay, to withdraw or to draw, okay, or extract the blood. Right, these are the two most common, no, okay, method. All right, the vacuum extraction system, okay, is most often used, okay, when vein is prominent. So we cannot use this, okay, if the vein is very, very small. Okay. All right, advantages: can obtain large amounts of specimen. Okay, how? Okay, when the first specimen, okay, inserted here, okay, in the holder, okay, is already full, no, you can insert another, okay, collection tube, no, okay, hanggang sa magsawa ka. Hindi, joke lang. Hanggang sa makompleto mo, okay, yung specimen mo. Okay, all right. It is economical, okay, and quickest and safest method to obtain specimen. Okay, there is also a least risk, no? Okay, for accidental needle stick kasi unlike the syringe type, no, hindi ka na magta-transfer, okay, papunta doon sa collection tube. All right, disadvantage may cause small fragile veins to collapse, okay? Right? And not reposition easily if vein entered immediately kasi we cannot see flash of blood. All right. For the needle and syringe system naman, okay, it is most often used when the vein is hard to find, okay? Mga maliliit na vein, okay, mga malalalim na vein, okay, and mga fragile vein. Right? Advantage is you can have more control drawing hard to get small veins. Okay? And you can blood is also okay with the vessel. Disadvantage, increased risk of accidental needle stick. Right? Okay, so for the vacuum extraction, okay, this is the system. Okay, we have the holder and we have the two-way needle. Okay, so the two-way needle is just like this one. Okay, two-way needle, okay, or multiple collection needle. Okay, these are the two, okay, most common terms, okay, for this. Okay, two-way needle kasi this is a needle, okay, that will puncture the skin and vein of the patient, and this is the another needle connected to the holder, okay, that will puncture the rubber stopper of the collection tube. Okay. All right. Okay. So this is the holder, okay, connected to the two-way needle or multiple collection needle. Okay. And dito natin ipapasok yung collection tube. All right. Okay. This is a vacuum extraction system, okay, with built-in protection device. Okay, this one, no? Okay, this is the cup. Now, once you remove this cup, no, okay, to seal the needle, okay, all you need to do is to push this device, okay, towards the needle, okay, to seal, okay, the needle inside. So hindi na siya makakatusok. All right. Okay, another example of built-in safety devices, okay, for syringes, no? Ito, okay. Push nyo lang yan, okay? Papunta dun sa needle, malalak na, okay? Yung mismong needle. Okay? Or kaya naman, in this type, no? Okay, just have to push, no, upward, okay, the component, okay, outside the barrel, no? Okay, and it will lock the needle at once. Okay? All right. So the gauge of the needle indicates the size of the needle and refers to the diameter of the needle's lumen or bore. Okay, so the larger the gauge number, the smaller the diameter of the needle. Okay, for phlebotomy, okay, we have a recommendation which is 21 to 23. 21 for routine use and 23 for smaller veins. Okay, all right, so before you decide, okay, what needle you should use, okay, you have to assess first the vein, kung magkakasya ba. Okay, all right. Components of the needle, the barrel, the tip, and the bevel. Okay, always bevel up now when you do blood extraction. Okay, all right. Yeah, this is an example of a two-way needle. Okay. All right. Okay, butterfly needle, okay, is also used, okay, to extract blood. Okay, it is this is called a winged butterfly vacuum extraction system. Okay, all right. So this holder, okay, is connected, okay, to a butterfly, okay, with, okay, two-way needle, right? Okay, so this is used, okay, for multiple collection, okay, in toddlers, no, okay, and in agitated patient. Okay, all right. Lancet, okay, are used, okay, for difficult venipunctures, including pediatric draws. Okay. So ang ginagawa natin is, or what we do, okay, is the needle stick, no, okay, or needle prick extraction of blood. Okay, tourniquet, okay, is also one of the most important component, okay, of the phlebotomy. Okay, consideration, okay, do not leave for more than 1 minute. Okay, all right, maximum of 2 minutes pala. Yan. All right, 1 to 2 minutes, okay, to prevent the hemoconcentration. Okay. All right, cleansing agents, okay, 70% isopropyl alcohol, okay, or an alcohol prep pad, no, okay, will do, okay. Povidone iodine or betadine swab stick, okay, is also used, okay. But it is more specifically, okay, when we extract blood, okay, for the blood culture and sensitivity. Okay, soap and water, okay, is very necessary, okay, if the site of the venipuncture is obviously with dirt, no, okay, or very dirty, no, okay, when there is a trauma or vehicular accident, yung mga ganyan. Okay, cotton balls, okay, or sterile gauze pads, okay, should be used right after the blood extraction, okay, to hold pressure over the site, okay, to prevent the bleeding. All right, yeah, okay, OS, okay, or gauze, no, okay, or a band-aid. All right, then of course gloves, no, okay, it's very important. Okay, yeah, sharps container, okay, is optional, right? Okay, but it's a must. Okay, right. Black indelible ink, no? Okay, for to mark, no? Okay, or write, okay, the information in the or not in, no? Okay, to label, okay, the collection tube. Okay, all right. Okay, let's have a 10-minute break na, okay, before we continue collecting the blood. Okay, kasi our next segment na ngayon is how we collect the blood, the consideration, okay, for the collection of blood, okay, using different system, okay, or procedures. Right, 10 minutes lang. My time is 2:31. Okay, we will resume at 2:41. So, we need to resume. Okay, kasi pag umulan na, hindi nyo na ako marinig. No? Okay? All right. Let's resume the discussion, okay, with the collection of the blood specimen. Okay? All right. So before anything else, okay, you have to always greet the patient in a professional, friendly manner, okay, to establish the rapport, no, and trust. Okay, a good initial impression will earn the patient's trust, okay, and make it easier and more pleasant to draw a good specimen. Okay, right. So even if the patient's door is open, okay, knock on the patient's door, okay, before entering. Okay, identify yourself, okay, by the name and the department. Okay, and explain the reason, okay, for your presence. Okay. The more relaxed and trusting your patient, the greater chance of a successful atraumatic venipuncture. Okay. Good verbal listening and nonverbal skills are very important, okay, for patients' reassurance. Okay. Then, okay, make an identifications. Okay, we've already discussed this one. Right. Okay. This is the time, okay, that you now wash your hands. Hindi ka papasok, maghugas lang ng kamay basta-basta. Okay? You have to respect, okay, the space, okay, of the patient. Okay? All right. So apply gloves, okay, and you may explain, okay, to the patient, okay, the reason, okay, why you are wearing the gloves. No? Okay? Position the patient, okay, in comfortable position. Okay? You have to refer, okay, to the patient's preference, okay, kung nakahiga siya, okay, or kung nakaupo siya. Okay, turn the arm, okay, so that the wrist and palm face upward and the antecubital area is accessible. Okay, right? Then apply the tourniquet. Tie the tourniquet just above the elbow. Okay, not too tight and not too loose. Okay, the tourniquet should be applied not more than 2 minutes. No, again. This is how we, no, okay, position, okay, the person or the arm fist, okay, to further distend the arm vein. Okay, this is just to help, okay, the vein, okay, to be distended. Okay, but once you already hit, no, okay, the vein, okay, you may instruct, okay, the patient to open, okay, his or her hand, no, kasi it will not contribute, okay, to your blood extraction. Okay, all right. So again, okay, the sides, okay, that can be considered vein, okay, or vein, and you, okay, pull, okay, when additional palpation is required immediately before performing the puncture. Okay, often a patient has veins that are more prominent in the dominant arm. Okay, so you may ask the patient, okay, the dominant hand, okay, then doon kayo mag-extra. Okay, right. If you are considering the metacarpal vein, okay, make sure you have a support, no, okay, like this. Okay, all right. Again, never draw, okay, from these areas: scarred, abraded, or inflamed skin, arms containing IV catheters, okay, edematous arms, occluded veins, shunts, no, okay, just like AV shunts, right? Cleanse the site, okay, with isopropyl alcohol that is 70%, no, okay, isopropyl alcohol, okay. Back and forth motion, okay, for 30 seconds with friction. Okay, we do not anymore suggest or recommend, okay, the encircling motion, okay, of ginagawa. Okay, back and forth motion na for 30 seconds with friction. Okay, allow alcohol to dry. Okay, it can disinfect the site, okay, by allowing alcohol to dry and prevent a burning sensation, okay, during the puncture. Okay, all right. Remove the tourniquet, okay, as you wait, okay, for the alcohol to dry, okay, and prepare the materials. No, okay, if you're using the vacuum extraction system, okay, you have to assemble the materials. Yeah. Okay, now hold the vein in place, no, like this one. So you have to retract the skin towards you, okay, to hold the vein in place. Okay, then okay, provide 15 to 30 degrees, okay, angle, okay, and that is equivalent to the height of your finger, okay. The needle above the finger, okay, is equivalent to 15 to 30 degrees, okay, before you insert the needle, okay. So once you've already, okay, pushed or inserted the needle, okay, you cannot see a flashback, no, okay, in this system, okay. So all you need to do is to push the tube into the holder, okay. Once you see, okay, a sucking blood, okay, inside, you are in to the blood vessel wall. Okay, so gently push the tube onto the needle holder so that the catheter is inside, okay, inside the holder, okay, penetrates the tube. Okay, the blood flow, okay, should be visible, okay, at this point. Okay, allow the tubes to fill until the vacuum is exhausted, okay, to ensure the correct blood to anticoagulant ratio. Okay, or the collection tube, no, has been filled, okay, up to the level, okay, or the recommended level. Okay, if you do not see blood flow, okay, the tip of the needle, okay, may not be within the vein, or may have already passed through the vein, okay, or may have missed the vein entirely, okay, or maybe push up against the inside wall of the vein. Okay, all right. So then, can happen, okay, kung masyadong mababaw, no, okay, yung insertion mo, okay. Right? Kapag masyadong malalim naman, nag-through and through ka, okay, sa vein, okay? Or okay, if the vein, okay, is movable, okay, lalong-lalo na, okay, for it can be experienced, okay, in patients with uh, in 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 elderly, okay, na decrease ng elasticity ng skin nila, okay, and sa mga payat, okay, na walang nag-hold, no, okay, na muscle, right? Okay, maybe push up against the inside wall of the vein. This is due to the sclerosis, okay, or arteriosclerosis, okay, of the vein, okay. All right, so we have troubleshooting, yeah, okay. Change the position of the needle, move it forward. If incomplete collection or no blood is obtained, okay, or you may move it backward, okay, it may have penetrated too far, okay, or adjust the angle. The bevel may be against the vein wall, right? Or you can loosen the tourniquet. It may be obstructing the blood flow, okay? Or try another tube, okay? There may be no vacuum in the one being used. Or re-anchor the vein, okay? Veins sometimes roll away from the point of the needle and puncture site. Ito yung mga movable veins, okay? All right. Okay, hematoma is the number one problem, okay, during the blood extraction. Is the leakage, okay, of the blood, okay, into the surrounding tissue. Okay, if hematoma forms under the skin adjacent to the puncture site, release the tourniquet immediately and withdraw the needle and apply firm pressure. Okay, you must not continue your blood extraction. Okay, if the blood is bright red, this is probably, okay, arterial blood. Okay, so pwede naman yun kuhanin. Pwede naman yung i-extract. Okay, but may right collection is starting. Okay, keep a firm grip, no, okay, in the needle holder, no, like this one, okay, while pressing down on the patient's arm, okay, and use your other arm like this, okay, to interchange the blood collection tube. Okay, so tatanggalin mo yung napuno na, then papalitan mo ulit. Okay, all right, as much as you can, no, okay, or until, okay, you extract of the specimen. Okay, all right, there is an order of blood draw. Okay, all right, if you are using the vacuum extraction, okay, you have to use first, okay, the blue, okay, and last now is the lavender. All right, kasi the blue, okay, is for clotting time. Okay, this must not be contaminated by other additives. Okay, the EDTA tube, okay, or the lavender tube, okay, must be the last. Okay, it it contains anticoagulant. Okay, so it will alter, okay, the specimen, no, if it is being used, no, at first. Syringe extraction only, okay. When you transfer, okay, the specimen, okay, from the syringe, okay, and you have a blood culture bottle, always transfer first, no, into the blood culture bottle kasi sterile yung blood culture bottle. Okay? All right. Okay, so once you are through, okay, gently release the tourniquet before the last tube of blood is filled, okay, or before removing the needle. Okay? All right, remove the last tube, okay, from the needle and withdraw the needle into a single quick movement. Okay? All right? And apply pressure, okay, once you've already removed the needle. Do not apply pressure, okay, once the needle is still inserted kasi it is very painful. Okay? All right? Okay, then quickly place clean gauze over the site and apply pressure, and you may ask the patient to continue applying pressure until bleeding stop. If the patient can hold, okay, the puncture site, okay, while the patient is holding, okay, the site, okay, you can now get a tape, okay, a freshly cut tape, okay, to apply, okay, on the gauze. All right, okay. Okay, remove the needle from the holder. Appropriate and properly discard. Okay, all the waste and gloves, no, okay, in appropriate biohazard waste container, and wash your hands. Okay, specimen labeling, label the specimen, okay, and as much as possible, okay, or if possible, okay, you can show it, no, okay, to the patient, okay, for the double check. Okay, all right. If you are extracting blood, okay, through syringe specimen collection, this is how it looks like. Okay, this is for, again, okay, for small or delicate veins, okay, that might be collapsed, okay, by the vacuum of the evacuated tube system. Okay, it may also be used, okay, to collect blood culture specimen. Okay, and the principle of the extraction is the same with the blood extraction, vacuum extraction. Okay, all right. However, okay, if for example, okay, you only have one collection tube, okay, to be collected, okay, you have to use the 3cc only. Okay, right? So it depends on the amount of the blood you have to collect, okay, when choosing the size of the needle. All right. Okay, finger stick specimen collection, okay, you have to use the safety lancet. Okay, this is one of the examples of the safety lancet. Okay, all right, so for the finger stick, no, okay, if possible, use the fourth ring finger or the middle finger kasi it can heal faster, okay, than other fingers. Okay, and it is less commonly used, okay, by the patient. Many patients prefer that you use finger, okay, on their non-dominant hand, okay, para yung dominant hand magagamit pa nila. Okay, choose a puncture site near the right or the left edge of the finger tip, no? Okay, yung gilid mismo, hindi yung mismong gitna. Okay, and clean the site as you would for return of any puncture, but this time, okay, scrubbing, okay, technique, no? Okay, back and forth pero scrubbing technique. Okay, all right, yeah, no? Ito yung sa side part. Okay, select a safety lancet appropriately for the size of the patient's finger. Okay, and you may warm the finger prior to puncture, okay, to increase the blood flow. Okay, para madami kayong mapiga, no? Okay, make the puncture perpendicular rather than parallel to the fingerprint para hindi siya mabilis mag-heal. All right? Okay. Then away the first blood okay. Then this is how, so you have to, or sometimes for, and to help, no, increase the blood flow. Wipe the collection site with an alcohol prep pad. Okay, and wipe the site with sterile cotton or gauze to be sure all of the alcohol has been removed. Okay, then puncture the left or right side or outskirt of the heel, not the bottom of the foot like this. Na? Okay, so dito nyo lang siya, saan yan? Dito nyo lang siya i-prick. Okay, not at the center. All right, wipe away the first drop of blood. Okay, again, okay, just like the finger stick. Okay, and then scoop, no? Okay, the blood. Okay, just like in the finger stick collection. Okay, do not squeeze. Okay, the infant's foot, okay, too tightly and wipe with alcohol during collection. It may be contaminated by the alcohol. Okay, after collection is completed, apply pressure, okay, to the puncture site with a sterile gauze pad until bleeding has stopped. Okay, and do not apply an adhesive bandage to an infant's foot since it may injure its delicate skin. Okay, manipis pa ang balat nila. Okay, all right. Butterfly, okay, is also used, okay, for pediatrics. All right, yan. Okay, especially, okay, if this is connected to the holder, okay, magiging vacuum extraction na siya. Okay, and this is recommended for pediatrics with large amounts of collection. Okay, all right, this is how it looks like. Okay, this is butterfly, okay, syringe system, and this is butterfly, okay, vacuum extraction system. Okay, this is used, okay, for a small amount of pwede rin, no, okay, na large amount, okay, of specimen, okay, but this is most or more preferably, okay, to use, okay, for pediatrics na galaw ng galaw. Okay, all right. Special situation, okay, if someone hesitates, okay, to let you collect a blood specimen, explain to them that their blood test results are important to their care. Okay, patients have a right, no, always, okay, to refuse blood tests. Okay, but if the patient still refuses, okay, perform and document report, no, and document patient refusal. Okay, if there is a fainting, okay, it is therefore important that the patients are, okay, properly seated or lying in such a way during venipuncture so that if they do faint, they won't hurt themselves. Okay, all right. It is usually self-limited only. Okay, but to manage this kind of situation, okay, gently remove the tourniquet and needle from the patient's arm, apply gauze and pressure to the skin puncture site, and call for help. Okay, if the patient is seated, place his head between his knees, now like this one. Yan. Okay, it can help the blood, okay, to flow into the head of the patient. Okay, if there is a nausea and vomiting, a cold compress on the back of the neck may help to revive the patient more quickly. All right? Okay. What are the unsatisfactory, no, okay, specimen? Ito yung mga, okay, hindi tinanggap, no, okay, ng laboratory. Okay? Kasi they can cause misleading laboratory results, and therefore, okay, another extraction, okay, should be performed. Okay? All right. Now, what are these? Okay, hemolyzed, okay, clotted, insufficient, and mislabeled. Ito yung mga binabalik, no, ng laboratory. Okay? All right. Hemolysis is like this, no? Okay, after the centrifuge, okay, after this, okay, hemolysis means the breakup of fragile red blood cells within the specimen and the release of their hemoglobin and other substances into the plasma. The hemolyzed specimen can be recognized after it is centrifuged by the red color of the plasma, no, like this one. Okay, kasi dapat ganito ang kulay niya. Okay? Right? Dalawa lang ang division, okay, ng kulay niya. Okay? Light yellow, okay, or cloudy, no? Okay? And dark red. Okay? Yun lang ang kulay dapat. Okay? All right. So using causes of hemolysis using a too small needle for a relatively bigger vein. Okay. So the bigger the vein, okay, the bigger the needle must be used, okay, to prevent the hemolysis. Okay. Pulling a syringe plunger too rapidly. Okay. So you just have to assist, okay, the needle. Okay. Be careful when pulling the plunger, okay, towards you. Okay, it must be very slow. No, expelling blood vigorously into the tube. No, shaking a tube of blood too hard, it must be inversion only. No, or figure of 8 only. No, underfilling a tube, okay, so that the ratio of anticoagulant to blood is greater than 1:9. Failing to let alcohol or disinfectant to dry, using too great a vacuum. Okay. Hemolysis can cause falsely increased potassium, magnesium, iron, and ammonia levels and other aberrant lab results. Okay. Clots. No? Blood clots, okay, when the coagulation factors within the plasma are activated. Blood starts to clot almost immediately after it is drawn unless it is exposed to an anticoagulant. Clots, okay, within the blood specimen, even if not visible to the naked eye, okay, will yield inaccurate results. Okay, so causes inadequate mixing of blood and anticoagulant. No, yung right after you transfer the specimen into the collection tube, no, iniwan mo na lang, hindi mo na minix, no? So you have to invert, no, okay, immediately. Okay, delay in expelling blood within a syringe into a collection tube. Okay, all right, insufficient volume, okay, kulang, no, okay, yung specimen. Okay, causes short draws, okay, will result, no, in incorrect ratio, okay, of blood to anticoagulant and yield incorrect test results. Okay, vein collapsing during phlebotomy, okay, is another cause, no? And the needle coming out of the vein, okay, before the collection tube is filled. Na nanginginig ka, tapos biglang unti-unti, no, nahuhugot mo na pala yung needle, no, bago mapuno yung required amount, okay? Or the loss of the collection tube vacuum before the tube is full. All right. We have any questions? Question po? Wala. Okay. So tinatamad na kayo, no? Na makinig. All right. The last topic is the arterial, no? Okay, blood extraction. Yeah. Okay. Arterial blood sampling, okay, is primarily, okay, performed, okay, when there is an ABG analysis, okay, or okay, if it's very hard, okay, for the venous extraction, okay, to be done, okay, all right. The choice of site, okay, for the for the arterial blood sampling is radial artery, okay, brachial or femoral, okay, all right. But the radial artery, okay, is the most common because it is the most accessible, okay, and the easiest. Okay, all right. The brachial or femoral arteries may be harder to locate because they are less superficial than the radial artery. Okay, the radial artery is located on the thumb side of the wrist. No, okay. The brachial and femoral arteries have poor collateral circulation. Okay, and are surrounded by structures that could be damaged by faulty technique. Okay, kaya radial artery is the one, okay, that we recommend initially. Okay, all right. Equipment, okay, of course, you have to pre-heparinize the syringe. Okay, there are syringes, okay, that are already prepared, okay, with already prepared for the arterial extraction, okay, with heparin nasa loob. Okay, all right. Okay, now procedure, okay, for arterial blood sampling. Okay, approach the patient again, introduce yourself, okay, and the procedure to be done. Place the patient on their back, lying flat. No, this is the more recommend. This is the recommended position of the patient kasi the patient may faint, no, okay, afterwards. Ask the nurse, okay, for assistance if the patient's position needs to be altered, okay, to make them more comfortable. Okay, locate the radial artery by performing an Allen's test, okay, for collateral circulation. If the initial test fails to locate the radial artery, repeat the test on the other hand. Okay, once a site is identified, note anatomic landmarks to be able to find the site again. If it will be necessary to palpate the site again, put on sterile gloves. Okay, all right. Perform hand hygiene. Disinfect, okay, the site, no, as you would, okay, when doing the venipuncture, okay, and prepare the materials, no, while you are waiting for the alcohol to dry. Okay, holding the syringe and needle like a dart, okay, using the index finger to locate the pulse again, like this one. Okay? So holding the needle, okay, like a dart, no? Okay, use another finger, okay, to locate the pulse again. Okay? Inform the patient that the skin is about to be pierced, okay? Then insert the needle at a 45-degree angle, approximately 1 cm, distal to the index finger. Okay? All right? Okay, so this is 45 degrees. Okay? It must be at least 1 millimeter, okay, away from this finger. Okay, this finger is your guide. Okay, will say doon ka mag-insert. Okay, but make sure you do not touch, okay, the site of venipuncture or the arterial or the puncture. Okay. All right. To avoid contaminating the area while yes. Okay. We do not hold or touch again puncture site, okay, to avoid contaminating the area. Okay. So advance the needle into the radial artery until a blood flash appears, and allow the syringe to fill to appropriate level. Okay. You can help the syringe, okay, from sucking the blood, okay, very carefully, no, okay, by simply pulling the syringe. Okay, pero mabilis lang yan mapupuno kasi yung pulsation, okay, push the blood into the syringe. Okay? All right? So withdraw the needle in the syringe and place a clean, dry piece of gauze or cotton wool over the site, and have the patient or an assistant apply firm pressure for the sufficient time to stop the bleeding. Check whether the bleeding has stopped after 2 to 3 minutes. Okay, 5 minutes or more may be needed for patients who have high blood pressure or a bleeding disorder or are taking anticoagulants. Okay, all right. Okay, for the ABG, expel air bubbles, cap the syringe, and roll the specimen with the hands to gently mix it. Okay, again, hindi basta-basta tayo nagmi-mix, no? Okay, you just have to roll the specimen between your hands. Cap the syringe to prevent contact between the arterial blood sample and the air, and to prevent leaking during transport to the laboratory or to the respiratory department. Okay, of course, you have to label the syringe and dispose all the materials. Okay, remove gloves, okay, and other contaminated waste, and check for the patient site for bleeding. Okay, all right. Question? That concludes, okay, our lecture, okay, for the phlebotomy and blood extraction. All right. May I know if you're still there? Okay, can you do thumbs up? Ayan. Okay, and pwede ba tayong magpakita na kay sa camera? Okay, before we part ways. Ayan. Yan. Okay, hi Maribel. Yan. Hi Miss Maribel, Miss Emily, Miss Ronaline, and the companion. Okay. Miss Narisa. Okay. All right. Meron pa ba? Okay, yung iba, I'm sure wala. Okay, si Sir Joselito, okay? Nandyan ba? Si Zyrene, si Mary Rose, si Mikhail. Si Oppo, no? Okay? Si Oppo. Okay? Mukhang nagisa na si Oppo. Okay, all right. Okay, if you do not have any questions, okay, thank you very much. Okay? Miss Joy, okay, if you're there, no? Okay, or the admin okay, of WePump, no, if you're there, okay? Thank you very much again. Okay, the floor is yours, no? And guys, thank you very much, okay, for staying in, no? Okay, let me have a picture, okay, of us, no? Okay, together. Okay, please open your cam. Okay, we'll do screen chat. Okay, para meron akong remembrance ngayon. Open your cam na. Okay, in count of 3. Okay, smile, no? Okay. So 1, 2, and 3. Ayan. Okay? Alright, isa pa. Na? Yung waki naman, waki. 1, 2, 3. Yan. Okay? Alright, yung jump shot naman, jump shot. Hindi, joke lang. Alright? Okay, so thank you very much again. Okay? So I think ilan lang kayong nagstay. No? Okay, thank you very much. Okay? And always keep safe. Okay? Alright? Bye-bye. Okay? We pump, no? The floor is already yours. So for the further instruction. Thank you very much, guys. Thank you.
Hello po. Yung mga gusto pong mag-avail po ng hard copy po ng certificate po, pwede naman po additional 200 pesos lang po. Free shipping na po siya.